Good evening, friends. A warm welcome to all of you on this evening of Saturday, the beginning of a weekend. It's a home weekend as usual. So we have got you this webinar on behalf of the Association of Maharashtra Obstetrics and Gynecological Societies in association with the Foxy Midlife Management Committee and the Foxy Food and Drugs Committee in association with the Indian Menopause Society. So I bring greetings to you from MOG's President Dr. Nandita Palshetkar, MOG's General Secretary Dr. Arun Nayak, Foxy President Dr. Alpesh Gandhi, Foxy Secretary General Dr. Jaideep Tang, and Foxy Vice President in charge of this committee Dr. Anita Singh Madam, and also from the IMS, the Indian Menopause Society, wherein the Foxy Midlife Management Committee has partnered or associated with the Indian Menopause Society to have a series of programs. So from President Dr. Jignesh Shah and from the Secretary General Dr. Anita Shah. Dr. Nandita Palshetkar Madam was supposed to be joining us to welcome all of you, but she is right now in another webinar, which is like it has got extended a bit, so she will join us in some time. So we now move on to the program. Basically, thanks to advances in nutrition, diet and healthcare, the life expectancy of women has increased in today's world, more so for women. So the midlife happens to have sort of sprung up from this increased life expectancy. And this is a unique period in a woman's life with changing roles as regards family, as regards social life, professional life, and personal longings. She can, go back to her hobbies, and she can do whatever she likes because she's in that sort of a tri-zone of her life. But at the same time, it also sees a lot of extensive physiological changes, including those of what we call the menopause or climacteric. And unfortunately, this can also be a time when specific health problems can manifest themselves, like the vasomotor symptoms of menopause, like the vulvovaginal problems, osteoporotic changes and fractures, weight gain, urogynecological issues, and sometimes even life-threatening issues like endometrial cancer. So to discuss these problems, and particularly so, we have selected a few specific problems. We have an elite panel of speakers who will help us tackle and manage some of these problems. And we are truly fortunate to have them with us. I, Dr. Rajendra Nagarkatti, chairperson of the Foxy Midlife Management Committee and also chairperson of the MOG's Midlife Management Committee. Once again, welcome all of you. And I'm the moderator for today. Along with me to moderate this session, I have none other than young dynamic Dr. Jyoti Jaiswal, who is a professor and unit head of the Department of Obstetrics and Gynecology, Pandit JNM Medical College, Raipur. She has done extensive work in perimenopause and in midlife management. And I'm really fortunate to have her with us today as one of my co-moderators. She is also chairperson of the quiz committee of the IMS India, chairperson of the medical education committee IMS just before this, that is 2017-19, a past president of the Raipur Menopause Society, a past general secretary of the Raipur Obstetric and Gynecological Society 2016-18, organizing secretary of the 4th International Conference of South Asian Federation of Menopause Societies, SEFOMS. She's also she was the organizing secretary of the 22nd National Congress of the IMS in Raipur, organizing secretary of the 10th, 11th, 12th, and 13th State Annual Conference of invited guest faculty of various international, national, and state conferences. I was in Raipur and a witness to their hospitality, which we had a lovely state conference there last year. So now moving on to the panelists. I would like to begin with none other than Dr. Maninder Ahuja Madam. She is the director of the Ahuja Healthcare Dental and Infertility Clinic. 40 years of dedicated work for women from adolescence to menopause menopause management and midlife management is something very, very dear to her heart. We have seen her doing extensive work in this particular field, and her videos and her innovative and I would say encouraging talks have literally moved us to accept this as a branch of obstetrics and gynecology. Present affiliation, she is founder president of the Society of Midlife Management, president of the Indian Menopause Society 2014-15, vice president of SAFOMS 2019 to 21, deputy secretary general of the South Asian Federation of Menopause Societies, was in the year 2013 to continue. Vice president Foxy 2013-14, founder chapter secretary IMS Faridabad, president FOGS, that's the Faridabad Obstetrics and Gynecological Society from 2008 to 12, founder chairperson of the Haryana chapter of ISPAT, chairperson of the Haryana chapter of ISAR. She's authored many books and has many publications, original research work in GE. She's got the Best Foxian Award in 2008, a lot of other awards. She's also the associate editor of the Journal of Midlife Health and peer reviewer for SAFOM's journal and many other publications. So I welcome you all. Welcome you, madam. She is also
thank you
coordinator for my midlife management committee, and I am really proud and honored to have you, madam. Next, we have with us, none other than Dr. Rajendra Singh Paradesi, again an iconic figure. He has mentored me in my entry in Foxy, and I'm really, really grateful and honored to have you with us today, sir. He's got 6 times Best Paper Awardee in National Foxy National Congress, that is AICOG, ICOG, AICOG 2011, 13, 18. Sir, you must have had many awards other than this also. Yes, he's 27 papers presented, 4 papers in FIGO, 3 papers in EOFOG, in Archie's World Congress, 1 paper in Yuva SAFOG, Foxy Congress, 2 times faculty speaker at 2 times faculty speaker at AICOG 2011, Taiwan AICOG 2013, Bangkok, 2 times faculty speaker to FIGO 2011 and AICOG 13, that is at Taiwan, 2 times co-chairperson at FIGO 2006. He was, it's not mentioned here, but I think it's in another slide. He is a Foxy vice president immediately the last year, that is 2019-20, and he has done extensive work in osteoporosis in Aurangabad and around, and he is very philanthropic, I can say. He's helped many poor patients with management of osteoporosis. So thank you for joining us, sir. The next panelist we have is Dr. Lakshmi Srikhande, madam. She is again a very dynamic person from the Orange City of Nagpur, medical director of the Srikhande Hospital and Research Center. She is one of our team of IVF centers which have been associated with Dr. Jaideep Tang, chairperson designate of the ICOG, the Indian College of Obstetrics and Gynecology. So we are hoping, looking forward to a fantastic year next year, madam, under your chairmanship. National corresponding editor of the Journal of Obstetrics and Gynecology of India, senior vice president Foxy 2012, patron and president ISOPA Vidarbha chapter, received the Nagpur Ratna Award at the hands of the Union Minister Shri Nitin Gadkari ji, received Bharat Excellence Award for Women's Health, received the Meru Dhara Hansotia Award for Best Committee of Foxy, National Governing Council member of ICOG from 2012 to 17, National Governing Council member of ISAR from 2014 to 19, National Governing Council member of IAG for 3 terms, and a chairperson of the HIV/AIDS Committee of Foxy from 2007 to 9. And so once again, welcome to Dr. Lakshmi Srikhande, madam, and she will be speaking on MHT step by step. The next panelist we have is dear friend Dr. Vidya Tobi from Vijayapur. She is a professor and head of the Department of Obstetrics and Gynecology at the Al Amin Medical College, Vijaypur, chairperson of the Food and Drugs Medico-Surgical Equipment Committee of Foxy. She is one of the co-conveners for this program. Along with the Foxy Midlife Management Committee, we have the Foxy Food and Drugs and Medico-Surgical Equipment Committee. Wonderful to have you, and we should continue to have such joint programs. It would be really helpful to the Foxians. National corresponding editor of the Jogi, that is the Journal of Obstetrics and Gynecological Societies of India, organizing chairperson of the KSOGA 2016, treasurer KSOGA, EC member of the Karnataka AGOI, academic council member of the Women's University Vijaypur, Al-Amin Journal of Medical Sciences editorial board. She's an undergraduate, postgraduate examiner, and with a teaching experience of 30 years. So we are very, very fortunate to have you with us, madam, and she's going to be speaking on a very interesting topic, that is diet, nutrition, and exercise in fitness. So welcome, Madam Vidya Thobi. So let's set the ball rolling. I will just ask Dr. Jyoti Jaiswal to take over and say a few words, and we can start with the first of the cases.
Thank you so much, Dr. Nagarkati, to involve me in the program. And this is really a wonderful platform where the different aspects which are required to be together for management of midlife women are all together here with all the stalwarts. So without taking much of the time, I will request Dr. Manindra Ahuja, madam. She is one of the legend of the Indian Menopause Society. And I think the first talk is to be started from Dr. Vidya.
Okay.
Am I audible to you all?
Yes.
Yes.
Vidya,
So,
Lakshmi is there.
Vidya to share her screen. And
Yeah, I share my screen.
have your screen, and may I invite you for your talk, because in this particular time, in the COVID time, the practice needs much more attention on all those aspects which you are about to tell us. So the screen is all yours, Dr. Vidya Thobi.
Vidya, madam.
I think there is some internet issue.
Madam, we can't hear you. Dr. Vidya, madam, can you unmute yourself?
The screen is still. Dr. Vidya's screen is still.
विद्या
I think
सुरू
there is some.
is frozen.
विद्या काही प्रॉब्लेम आलाय का विद्या
Hello.
सुरू कर
We can see her screen. So welcome, Vidya madam.
No, I have muted. I think I am muted. Hello.
Seshan.
Yeah, we can hear you, madam. Just be a little louder.
Yeah, we can hear you.
Yeah, I am audible. So I thank Nagarkati to be. It is.
Dr. Vidya has logged
Hello.
in from. Yes, Vidya madam, we can hear you.
But you can see my screen.
We were able to presently we can see.
Previously we could see, but now no more. We are seeing you are logged in from two devices.
Logged in from. I don't know why the screen.
विद्या शेयर स्क्रीन करना
You go to share screen.
I have done the sharing of the screen.
पहिल्यांदा आला होता तुझा चांगला.
Because from two devices simultaneously creates confusion.
I think your phone is also on, madam, and your laptop is also on. Is it?
Yeah,
Vidya,
yeah.
madam, you are
From two
muted.
devices.
Vidya, madam,
And
you are
share
muted.
again.
And her laptop is muted, and I
Yeah.
think phone is unmuted. That is the problem. Yeah, yeah. Good. Good. Now you good. Yes.
Now I have to
Vidya,
share my
madam, you have
screen,
to
right?
log out from one device.
Yeah, I'll do that. Now you can see my screen.
Your laptop is also on. Is it?
Yeah.
Madam, you are muted. Vidya, madam, you are
And her laptop is muted, and I think phone is unmuted. That is the problem. Yeah, yeah. Good. Now you good. Yes.
Vidya, madam, you have.
I cannot share my screen right now.
In the down panel, you can see
I
green.
Yeah. Started.
आता कर.
No, but my screen I am not able
नाही
to
तू तुझे
share.
सिलेक्ट
We can
कर
see it, madam.
ना.
We can see it.
सिलेक्ट कर ना त्याच्यात तुझं. हा कर सिलेक्टेड.
I have to select my presentation.
It was showing previously, her slides were there.
Yeah, वरती आहे ना madam.
No, I have seen my desktop. Now I'll play. Now, can you share?
Yes.
Yes.
I can control this one, no?
Yeah,
Yeah.
you can control it from there.
Hold
You
it
can
from
start.
arrow.
Thank you very much, Amox, and thank you, Dr. Rajendra Nagarkatti. Yeah, I leave from this one mobile. So, sorry for the interruption, and thank you, Amox. Thank you, Dr. Rajendra Nagarkatti, Dr. Rajendra Pardesi, VP of Amox. And my co-panelists, Dr. Maninder Ahuja and Dr. Lakshmi Srikhande. So this is very important topic, and I would like to share some of my thoughts on this. So adequate nutrition.
And you have to be a little louder, I think.
Fitness is very much essential components of healthy lifestyle. So,
Madam, please check the volume.
Madam, volume check करा, volume कमी आहे.
To reinforce this. So let food back. I now okay.
अजून थोडंसं.
Madam, you can please reach up to the full volume.
Hello, Dr. Vidya, can you hear us?
Hello, can I speak from this?
Yes.
Now you are better audible, madam.
But madam, we cannot
this
see
is
your
from
slides.
my mobile.
We cannot see your slides, madam.
Yeah, now you have to start screen sharing again.
What, resharing the slides?
Yeah.
Oh my God. I don't know.
The green button आहे ना, खाली ते दाबा परत मॅडम. बटन आहे ना.
विद्या स्क्रीन शेअरचं बटन दाब.
Screen shares is dabbler, but I don't know.
नहीं येईल
Ma'am, it is easier to log in from the mobile. The volume will also come better. And you
But
can
the slides I will
share.
not be able to share. No, can you share from this?
Oh,
You
no,
can have
no.
a control from my desktop.
No. You have to be on the laptop or desktop for slide sharing.
Oh my God. I think those who can share, they can start their topic.
Yeah, I think what we'll do is, Madam Tumina, you email your topic to session.
That will be better.
Yes, and after
But I tried this earlier.
yeah.
So can we request Lakshmi Madam to start her
Yes,
talk?
we will start the next talk. Yes.
Yeah.
So thank you very much, Madam, for agreeing for your talk. And we will be having the pulse of wisdom from Dr. Lakshmi Srikhande about step-by-step MHT.
Thank you, Raju Nagarkatti, for inviting me here to deliver a talk on MHT step by step. The widespread use of hormone therapy in the 1980s and 1990s came to an abrupt halt in the early 2000s after initial finding of the Women's Health Initiative trial, which were published, and this study was terminated. Over the next several years, extensive reanalysis and assessment of the WHI data cast doubt about the validity of the original conclusions. In 2016, to atone for the turmoil caused by the inappropriately communicated findings of the WHI trials, two WHI investigators, they published a request for forgiveness. There is general agreement among guideline group that hormone therapy has a favorable risk-benefit ratio in women who initiate treatment between 50 and 59 years of age or within 10 years of menopause onset. In this population, HT is highly effective for relief of vasomotor and urogenital symptoms and can prevent bone loss and fracture. Symptom relief provides additional benefits such as improved sexual function and overall quality of life. The timing of starting of MHT is very important. The timing of initiation of hormone therapy, it affects the relation with its coronary risk factors. Estrogen may provide coronary benefit in early menopause, but may harm if started later. Absolute risk of hormone therapy are lower in early than late menopause. Hormone therapy is appropriate for vasomotor symptom relief in early menopause. Hormone therapy is not recommended for chronic disease prevention. So here I am telling you how to go about with menopausal hormone therapy in 5 steps. Step 1 is to assess if MHT is right for your patient. Step 2 is what are the options. Step 3 is actually starting the MHT treatment for your patient. Step 4 is follow-up, and step 5 is stopping treatment. So let us see the first step, how to assess your patient. In short, you should know what are the indications where you can start MHT for your patients. The hormone therapy has been shown in double-blind RCTs to relieve hot flashes and is approved as first-line therapy for relief of menopause symptoms in appropriate candidates. In prevention of bone loss, it has been shown in double-blind RCTs that it prevents bone loss, and in the WHI, it has been shown to reduce fractures in postmenopausal women. In premature hypoestrogenism, it has been proved that it helps in hypogonadism, premature ovarian insufficiency, or premature surgical menopause. Of course, women should not have any contraindications for starting MHT, and it provides health benefits for menopausal symptoms, prevention of bone loss, it improves the cognition and mood issues, and in observational studies, it has been proved to be beneficial for heart diseases as well. Hormone therapy has been shown in RCTs again to effectively treat the symptoms of vulvovaginal atrophy. When we know indications before starting, of course, we have to know the contraindications. So what are the contraindications for starting MHT? These are current, past, or suspected breast cancer, known or suspected estrogen-dependent malignant tumors, undiagnosed genital bleeding, untreated endometrial hyperplasia, previous idiopathic or current venous thromboembolism, active or recent arterial thromboembolic disease, untreated hypertension, active liver disease, known hypersensitivity to any of the active substances in the drug, and porphyria cutanea tarda, which is an absolute contraindication to starting MHT. The main risk factors for HT use are older age, that is more than 60 years, obesity, where BMI is more than 30, if patient is having insulin resistance, if patient is having dyslipidemia, hypertension, diabetes mellitus, or she has history of smoking, or she gives personal or family history of venous thromboembolism. But the presence of risk factors does not necessarily preclude the use of hormone therapy. So in the presence of these systemic diseases, how to go about starting MHT? If she is already more than 60 years of age, or she is more than 10 years postmenopausal, for the current user, if she is already continuing, it can be continued at an appropriate dose for an appropriate time if no new contraindications emerge. For new users in whom HT is really indicated and in the absence of major contraindications, treatment with transdermal estradiol, either 25 microgram patch or gel, and vaginal progesterone, either 100 milligram in the evening continuously or 200 milligram in the evening for 14 days a month is preferred. If other risk factors are present, vaginal treatment with estradiol or estrol is preferred. If she is having obesity, that is BMI more than 30, then the elevated estrogen production from the adipose tissue increases the risk of proliferative endometrial lesions, and protecting the endometrium with progesterone or progestrogens is a top priority. And here the women's willingness to make lifestyle improvement should be empowered. In presence of insulin resistance, MHT should be recommended to women with type 2 diabetes or a family history of diabetes, as it reduces the progression of the disease. If she is having hypertension, menopausal HT can improve the recent onset hypertension with enhanced response to antihypertensive drugs, and the option to start transdermal HT should be discussed with a cardiologist. If the women who smoke, they should be counseled to quit while also increasing the daily aerobic exercise in order to improve the endothelial function, reduce hypertension, and if relevant, reduce the risk of weight gain. For women who choose not to quit, vaginal HT is preferred. In selected cases, systemic HT may be considered, but only if the woman is fully aware of the higher independent cardiovascular risk due to smoking. Dyslipidemia, transdermal MHT is preferred. Same with venous thromboembolism, vaginal HT with estradiol or estradiol is preferred. So coming to the step 2, what are hormone therapy options? Traditionally, it is estrogen replacement therapy for women without a uterus, estrogen progesterone therapy for women with intact uterus. Estrogen is the primary active component of HT and is the recognized gold standard for treating menopausal symptoms, especially vasomotor symptoms. Systematic estrogen used for MHT in India are conjugated equine estrogens and estradiol valerate. Estradiol valerate is the most trusted form of estrogen. It is natural estrogen, safer than its synthetic counterpart. The micronized form increases its dissolution and bioavailability. Esterified prevents extensive first-pass metabolism in liver and GIT. It has convenient oral administration and is safe even for long-term use. This is comparing, the slide is comparing the estradiol valerate with conjugated estrogen. And as you all can see, estradiol valerate has got many advantages over CEE when it comes to mammographic density, whether the effects on blood pressure or coagulation factor is considered. In hot flushes, it offers the favorable lipid profile. It also improves the endothelial function. So it is the first choice when it comes to prescribing estrogens. The vaginal estrogens are available in vaginal creams, vaginal ring, or vaginal tablet inserts for the treatment of genitourinary syndrome of menopause. If you are using vaginal estrogen, then the endometrial surveillance with either TVS or endometrial sampling is not required even with long-term use, but it should be considered with higher doses or more frequent applications. Progesterone therapy is not recommended with low-dose vaginal ET, but appropriate evaluation of the endometrium should be performed if vaginal bleeding occurs given the limitations of the safety data. So this was all about the estrogens in MHT. Let us see what is the rationale of progesterone in MHT. Since chronic unopposed exposure of the endometrium to estrogen increases the risk of endometrial hyperplasia and cancer, progestrogens are a part of systemic HT in menopausal women with an intact uterus. How to select the best progesterone for this particular patient? Although selecting the best progesterone for use in an individual patient requires further clarification, there is evidence to suggest that micronized progesterone have better risk profiles than medroxyprogesterone acetate and is associated with a lower risk of breast cancer compared with other progestrogens. An international expert panel is recommendations on MHT containing micronized progesterones are as follows. Oral micronized progesterone provides endometrial protection if applied sequentially for 12 to 14 days per month at 200 mg per day for up to 5 years. Vaginal micronized progesterone may provide endometrial protection if applied sequentially for at least 10 days per month at 4%, that is 45 mg per day, or every other day at 100 mg per day for up to 3 to 5 years. Remember, transdermal micronized progesterone does not provide endometrial protection. The different routes available for MHT is transdermal, whether in the form of patch or gel, oral and vaginal. The most appropriate dose of HT depends on the woman's phase of life, age, and general health status. Useful approach may be to start HT at a lower dose, then titrate upwards to the lowest effective dose that is consistent with the women's treatment goals. Now coming to the step 3, that is starting MHT treatment for your patient. International guidelines recommend that HT be started as soon as menopausal signs or symptoms appear, which in most women is between 45 and 55 years of age. Women with primary ovarian insufficiency require earlier and continued use of HT to protect against associated postmenopausal chronic diseases. So how to evaluate the risk factors for MHT in your patients? You have to ask the questions regarding her age, menstruation status, menopausal symptoms, past and current medical history, family history, and lifestyle factors, that is history of smoking, alcohol use, exercise, and history of concurrent medications. In the examinations and investigation part, you have to see her body weight, waist circumference, blood pressure, blood test if indicated by responses to your questioning, imaging, that is ultrasound, bone density, but if indicated by responses to questioning, not necessary in all the cases, mammography if not performed within previous year, bone densitometry if patient is at risk of osteoporosis. So this is the practical approach. If uterus is intact, you can give oral E plus P or combined transdermal E plus P patch. Post hysterectomy, oral estrogen or transdermal estrogen patch or gel. It can be given in the form of cyclical, sequential or continuous form. In the cyclical or sequential HT involves daily administration of estrogen with the addition of progesterone for 10 to 14 days a month. That is, your patient will be having monthly bleeds, or for 10 to 14 days every 13 weeks. That is, patient will be having withdrawal bleed every 3 months. Any irregular bleeding and or spotting that occurs in addition to regular progesterone withdrawal bleed can be managed by increasing the estrogen dose as this stabilizes the endometrium. In continuous HT, this regimen eliminates the withdrawal bleeding and it promotes amenorrhea. Should be used only in women who are at least 2 years past their last menstrual period, as it can cause irregular bleeding in perimenopausal women due to the unpredictable residual production of estradiol by remaining primordial ovarian follicles. So once you have started MHT to your patient, how you will do the follow-up of this patient? Once you have started, call her for your first visit after 1 month or before that also if she is facing any adverse side effects because of MHT. Assess the treatment effect on her. The adverse effects of MHT include bloating, breast tenderness, increased blood pressure, headaches, fluid retention, and urinary incontinence. How you will be managing these problems? If she is having persistent vasomotor symptoms, increase the MHT doses or try another formulation. If she is complaining of breast tenderness, reduce the dose of estrogen or switch to another progestogen. If she is complaining of unscheduled bleeding within the first 3 months, then what should you do? Consider continuing treatment unless there is a high suspicion of endometrial cancer, as bleeding may settle with time. Other options include switching to cyclical progestogen for patients taking continuous progestogen, increasing the dose of progestogen, or switching from oral progestogen to a levonorgestrel IUD. What to do if there is unscheduled bleeding after the first 3 to 6 months of MHT? You can organize further investigations for endometrial cancer, and if no endometrial pathology is detected, you can consider increasing the estrogen dose for this patient. When to stop the treatment for this patient? Current users of HT can remain on treatment indefinitely, that is lifelong if indicated, or at least until such time as the patient asks to stop. Regular monitoring of HT is advised with adjustments made to the type, dosage, and or route of administration according to a patient's changing circumstances and treatment goals. To conclude, MHT is a dominant therapeutic modality in climatic medicine. The skill lies in the ability to choose the optimal MHT preparation for the given patient. Follow the steps when it is decided that you want to start MHT by both patient and the doctor. I have already described five steps, how you should go about it. But the key is individualization, minimum possible dose, and early start of the therapy. Thank you all for your patient hearing.
Thank you very much, Lakshmi Madam. It was a wonderful and a very, very crisp talk. Each and every aspect was touched, but it was touched in a nutshell. Thank you so much. And I must be informing here, Dr. Raju, that we have a very friendly relation with the Lakshmi Madam. She always has been a part of all the programs of the Raipur Obstetric Gynae Society and Raipur Menopause Society. So we have in a long run, we have been together for a longer time.
Yes.
And one more thing I wish to inform here that till this time, 650 people already had been logged in to see this webinar. Questions I am not having at present, but as you suggested, madam, like for the estradiol valerate, you have given a very, very clear-cut message that estradiol valerate is a very good option and it can be a first choice. And another query remain in the mind of the all who you want to prescribe menopausal therapy, but while prescribing vaginal menopausal therapy, they just give it for a very shorter time, and they think that for the longer time if we'll give, it will be difficult to manage the endometrium, and there may be the need for the progesterone supplement. But it has been very, very clear that even up to for the time of 1 year, we can use menopausal hormone therapy in the vaginal cream forms for up to 1 year without need of any supportive progesterone. Yes, just a follow-up is very, very important. So now so thank you very much, Lakshmi Madam. I think Madam is ready with her talk.
Yes, I could share my screen now.
These are technical glitches, Madam. It happens.
So many times it happens.
Yes, it happens.
So now, without wasting any time, I am presenting you to all Dr. Vidya Thobi. She is She is going to talk about the diet, nutrition, and fitness in the midlife, a very important talk in the present scenario.
Thank you for the kind introduction, and I thank Dr. Rajendra Nagarkatti for getting me this association, as well as I thank AMOS, Dr. Nalita Palshikar, and I thank Dr. Rajendra Pardesi, Vice President AMOS, and my co-panelists as well, Dr. Lakshmi Shrikhand and Dr. Maninder Ahuja. I just wanted to have this topic since long, because as we all are entering this midlife, our lifestyle changes, and the adequate nutrition, diet, and physical and mental fitness is very, very essential components of healthy lifestyle. And this menopause transition or midlife transition is an excellent opportunity for us to reinforce this. So this is greetings from Food, Drugs and Medical Surgical Equipment Committee, FOXY, and let food be thy medicine. That's what we all tell. This is a Hippocrates. Long ago he has told this, but we have to follow this nowadays, and it is an essential part of our life. Now, what is a therapeutic lifestyle management, or 3 what we call it as a 3 of our midlife management? One is eat right, exercise, and the medication. Okay, so this medication, I just wanted to tell that many of us in midlife, we always enter with some of the medications. They have metabolic disorders, and definitely it is a part of our lifestyle. So various factors, they influence our nutritional status with aging. One is always there is a hormonal change, and metabolic needs also go on changing with our aging lifestyle. So what are these therapeutic lifestyle management in midlife? These are the general recommendations. One is physical activity or targeted exercise, correct diet and nutrition. You should avoid alcohol and tobacco. Alcohol, no, not many of them, they are alcoholics, but I know that in periphery, in rural areas, there are many women who have that tobacco chewing. Then stress reducing strategies, one has to adopt this: meditation, pace, respiration, emotional stability, positive attitude, family involvement, spiritual attitude, and sleep. These are the few things one has to adopt in their life gradually. So what are the nutritional issues and priorities? So one should always think of basal metabolic rate and our energy requirements. There is always redistribution of fat and leading to various metabolic syndrome, as I told. And there is always a decrease of need of calories. The recommended dietary allowance for the midlife and the menopause is around 1900 calories after 50 years. Okay. And plus, whatever medications we are taking, the nutritional state, the appetite, the absorption, the digestion, everything changes. And plus, of course, one should always think of the social factors. Many of our women, they are alone, and we cannot go on telling about nutrition. They cannot go to the market and buy the things. So we have to see their family background. One has to maintain the healthy weight, and reaching and maintaining the healthy weight is very important for overall health, and it helps you to prevent and control many diseases. If you are obese, you are at a higher risk of developing the coronary artery disease, hypertension, type 2 diabetes, gallstones, breathing problems, and even malignancies. So we always talk of balance and nutrition diet right from our adolescent. Okay, so we always think of this pyramid. Okay, this pyramid contains, we know that there are macronutrients and micronutrients. Macronutrients are carbohydrates, proteins, and fats, whereas micronutrient contains vitamins, minerals, trace elements, antioxidant, then various phytoestrogens they gain importance in this midlife and old age. And we all know the base is always a carbohydrate. So these carbohydrates, they form around about 60% of our diet. And these are complex, simple, refined carbohydrates. which have, we should always prefer complex carbohydrates which is having low glycemic index, like millets, jawar, sprouts, and always avoid refined things like maidas and preparations and all those things. Okay, so always plan the healthy meals which include all food groups in diet: vegetables, fruits, milk and dairy products, cereals, grains, eggs, meat and beans, and fats and oils in right proportions. So there should be a diet modification as you go on aging. There are low energy dense foods like whole grains, cereals, and fruits and vegetables, which protect against the weight gain, overweight, and obesity. And there are high energy dense foods which include animal fats and other high fatty foods, confectionery, sugary drinks, which are the cause of weight gain and obesity, particularly when large portion of our food sizes are consumed. We should always avoid sugary drinks. They are simple sugars. They are very attractive, and people, they go and tend to take them, but they cause weight gain and obesity. And these are the fast foods, and which are very dangerous for our this growth and other factors. Now, about the fibers, I just want to add that one should always consume around 25 to 40 grams of fibers, and these we consume through the fruits and vegetables. At least our 3 portions of vegetables and 2 fruits. Like you can take a lot of cauliflower or brinjal or 100 grams of apple. This combination you can take, which can give you many of the fibers from your food. So just remember this diagram, like you have to choose as much as you can hold in both hands, vegetables, then choose an amount to the feast, fruit, grain and grain products and milk. Meat and alternate, you have to choose around the size of the palm of your hand and thickness of little finger. Cheese and fats and or in very less amount. These things also, and you have to choose amongst these fats also. Sugars always avoid. Salt you have to reduce. Oil only 2 teaspoonful per day. Fruits, vegetables, again and again these slides come, and we have to choose from these vegetables and fruits. Drink 8 glasses of water every day. So hydration is very, very important. And these things much matter is they contain like flaxseed, cinnamon, fenugreek, soft. You can sprinkle on the salad and curds. You should take this daily. So whenever you are choosing the food, there are healthy and unhealthy food choices. Like you can choose steamed brown rice than white rice and biryani. So you have got plenty of choices, and you have to choose. Just see on the right side, there are red marks. So these you should avoid. So you have to eat whole wheat roti instead of paratha and puri. So whatever is tasty on your tongue is not very good to your tummy and other things. You should always remember. So diet, you should divide, and you should always have a good breakfast. Snack on 4 nuts like almonds, walnut, dates, figs, apricot, pumpkin, sunflowers, seeds, and food which are rich in phytoestrogens like lentil, kidney beans, bengal gram, and soya beans should be included in diet. Most of them, this soybean flour is available in the market, so you can have a combination with your wheat flour. Now, these are the various things which are available and you should include in your diet. Bengal gram and spinach and various fruits. They are very rich in phytoestrogens, and they are essential in the midlife and old age. And these are the various things, pictures, and their phytoestrogen content is given. So these seeds you should eat in plenty, but remember they also contain the oils. So if you have to choose them, choose rightly, and you have to spread throughout your meals. So these are the things you remember whenever you're eating. And your serving size also matters. If you are taking flax seeds, powder or chutney, which is very famous and which is very much available, but you should include it like half a cup per day, flaxseed. And most important is sesame seed, til, what we call it as til. peas, chickpeas, these are available. And they contain the lignans and phytoestrogens and even zinc. Sesame seeds are very rich in zinc also. So zinc is again one of the immunomodulators. So nowadays it has gained very much importance because of corona. So we are always taking all the spices in our kitchen. Our Indian food is very rich in all these things. If you include all the spices, definitely we get all the contents which are needed. So Asian women consuming soya had very less hot flashes than the Western women. They did the studies, and they found this, that substituting soya nuts for non-soya protein in a diet, they consumed around 3 to 4 times, and which was associated in decrease in the hot flashes and improvement in various menopausal symptoms. So 25 grams of soya proteins and 101 milligram of glycans isoflavones. These are very important substitutes which we can have in our food when we start approaching our midlife. Now, nutrition, very much important is the calcium and vitamin D. And the recommended dietary allowance of calcium and vitamin D for an adult Indian at midlife is around 800 milligram per day to 1200 milligram per day. Upper limit of normal is 2500 milligram per day. Vitamin D requirement is around 1500 to 2000 international unit per day, and upper limit of normal is 10,000 international units per day. So you have to assess the total calcium intake, what you are taking from your dietary source, and if needed, supplements are used to correct the deficient balance. But we all know that we are all deficient in our diet. So usually calcium supplementations are needed. So intake should not usually exceeds 800 milligram per day. The risk of the various events like calculi, renal calculi are not observed with the recommended dosage of calcium. If you exceed more than 2,500 or 3,000, then many times we find that these women, if they don't drink much water, we get various calculi. The prevention of kidney stone is very much possible if you have to take the sufficient fluids, and you should prefer the calcium citrate as a supplementation. So these are the various calcium rich foods. You have to drink sufficient amount of milk. Around 1 liter of milk will give you 1 gram of calcium. Then along with that, you have to consume oranges or citrus food for the better absorption. And these are the various vegetables which give you the amount of calcium, but in right proportion: cinnamon, almonds, soya beans, and turnips and greens. Now, why the calcium deficiency occurs? One is lactose intolerance and limited use of dairy products. And if you consume the large amount of proteins or sodium, it increases the calcium excretion. If your diet is rich in oxalates, that also decreases the absorption, aging, and vitamin D deficiency. And long-term treatment with corticosteroids, thyroid hormone excess, and thiazide diuretics all will decrease the absorption of calcium. Then there are other bowel and digestive diseases that decreases the ability to absorb calcium, like inflammatory bowel disease or celiac disease. Now, amount of calcium, the elemental calcium is the actual amount of calcium in the supplement that body absorbs for the bone growth and other health benefits. So whenever you are choosing the calcium supplements, you have to see that the woman tolerates those calciums, the calcium salt is absorbable, the cost, and when she takes these calcium tablets. The limit of this calcium, 500 milligram of calcium at one time from food or supplements. This calcium should spread throughout the day. Start with 500 milligram per day, about a week, and gradually add more to reduce the side effects. Absorption of calcium is decreased when you take with foods rich in fats, iron, zinc, spinach, and coffee and alcohol or any antacids. Now, these are the various common calcium salts which are available, like calcium carbonate. Most of the tablets, they contain calcium carbonate, calcium citrate, calcium gluconate, calcium lactate, calcium phosphate, and trivacics. It has got a different amount of elemental calcium, like calcium carbonate will have 40% of the elemental calcium, whereas calcium citrate is 21, but if you see the absorbable calcium, the calcium citrate has got the maximum absorbability. Why? Because it does not require the stomach acid for absorption, and people over the age 50, it is better absorbed and it can be taken anytime, but it is costly. Whereas calcium carbonate needs acid to dissolve for absorption. Less stomach acid as age need more and may cause poor absorption. It has to be taken with meals, and it is the least expensive form of calcium. So most of our calcium, what we find is of calcium carbonate. And we also get some of the calcium forms like oyster shell, bone meal. They may contain lead and other toxic materials. So you have to choose your calcium very carefully. And secondly, one more thing is calcium gluconate, calcium lactate, and calcium phosphates. They have less calcium than other carbonate like citrate forms. Now, thyroid medication, corticosteroids, tetracyclines, and anticonvulsant and calcium should be taken separately. It should not be taken with iron, and it is contraindicated in patients with hypercalcemia, renal insufficiency, and it should be given in caution with nephrolithiasis. So what I told was, if you are giving excess more than 2,500 milligram, it definitely affects the kidney and can reduce the absorption of other minerals like iron, zinc, and magnesium. Now, another molecule which is very important in midlife is vitamin D. Vitamin D, we know that it has got a classical action on the calcium balance and bone metabolism. And the intestine cannot absorb calcium and phosphate adequately due to insufficient this vitamin D, leading to secondary hyperparathyroidism and lack of new bone mineralization. So individuals who have more vitamin D are able to absorb more calcium. So combination with adequate vitamin D, calcium levels of about 800 milligram per day can be achieved by healthy diet that includes daily intake of calcium rich foods. So we know this metabolism of vitamin D and how it maintains the calcium balance of the body. And usually we get a lot of vitamin D from the sunlight exposure. So this amount varies with the time of day, season, latitude, and skin pigmentation. It is preferable to get vitamin D through the sunlight by exposing 20% of the body surface or surface area for at least 30 minutes between 10 a.m. and 3 p.m. depending on the season, latitude, as pollution and skin pigmentation. So preferable is 11 to 2, and you should know that the skin should be exposed. So clothing, sunscreen, window, you should not apply sunscreen and lie, so it will not have any effect. And also pollution, it reduces amount produced. So environmental pollution, we had a nice talk yesterday. So vitamin D is very much necessary for calcium absorption. So always choose a supplement with vitamin D unless obtaining from vitamin D from other sources. Follow age group recommendation. Avoid going over daily combined total 2,000 international units from food and supplements. It is not necessary to consume calcium and vitamin D at the same time to get the benefit or of enhanced calcium absorption. So these are the vitamin D rich foods. I'll not go into details, all of us know. And this vitamin D deficiency, how you manage, you can give it the powder or 60,000 international units once a week for 8 weeks, preferably with milk, and one injection you can give to correct the deficiency, that is up to 6 lakhs international units, not to be repeated before 3 months, and may be given after the confirmation of persistence of low levels of vitamin D. So you have to do vitamin D, then only you start this. And you can give the maintenance therapy from the natural source or supplements, which is advised after the correction of the deficiency. So maintenance, this is a maintenance how you give. You can give the oral supplementation, you can give injection, or you can give simple 1,000 international units daily, which will raise the blood levels on an average of approximately 10 nanogram per ml. So these are the tips on the healthy eating in the midlife. One is enjoyable and variety of diet. Watch your weight and stay active. Eat plenty of fruits and vegetables. Opt for healthier fats. Eat plenty of fibers. Reduce your salt intake. Eat calcium-rich food. Boost your vitamin B through, again, variety of diets, vegetables. Keep well hydrated. Look after your teeth. Little sunshine is good for you. Then get enough sleep. Keep your brain stimulated. use it or lose it, and keep active. Now, after minding of the body, mind of the body, you have to mind your body. You have to take care of your body by doing aerobics, weight bearing, and flexibility and balance. So I'm very happy that Dr. Maninder Ahuja is there with us, and she teaches us very much about these fitness exercises. So what are the benefits of this physical activity? It is very, very important for the maintenance of the mobility and independent living. It improves the strength, balance, and coordination, which is highly effective in reducing the risk of falls. And we are listening from Dr. Rajendra Singh how to prevent the osteoporosis as well. It helps prevention of the various metabolic disorders, obesity. It has benefits on the bone, joint, and digestion. It improves the mental well-being. If you do exercise, endorphins are released. So definitely it helps in to prevent other mental well-being also, like depression. We know that so many psychiatric disorders, depression, anxiety are more in the old age. And also it is associated with a reduced risk of cognitive decline. So physical activity, these are the things you should always care of. The breathing exercise like pranayamas and onkara sadhanas, these are very important for our respiratory system also. And Kegel's exercise for our pelvic muscles. Now, walking is the most beneficial exercise, and it has people have forgotten it, but it is very simple, and simple modification can be done. Like you can get down from the bus one stop earlier, like parking away and walking for extra distance. So boost your overall health. And even it is of very greater benefit, like brisk walks that helps your heart rate. These exercise prescription. So always whenever you have menopause clinic or midlife clinic, you should have, it is a multifaceted. So you have to recommend, there is an exercise prescription also. It should include aerobics, muscle strengthening, breathing and balance, 30 minutes of moderate intensity physical activity, mostly 5 days a week. Muscle strengthening activity should be including 2 days a week, and 30 minutes for the fitness and reduce risk of chronic diseases. 60 minutes of day for the prevention of weight gain. And once you have achieved that particular weight, then you have to maintain that weight also, 60 to 90 minutes per day to avoid regain of that weight loss. Okay. Now I have particularly want to show Maninder's photograph here. She has done so many modification, and she always she's so enthusiastic, and she always say that these are the various exercises you must do. And she had posted some videos also. I have taken from one photo from her presentation. So these are the stretching exercises and resistance and weight bearing exercises in the midlife and menopausal. Of course, you should start doing exercise right from your adolescent, but it should become a habit, what I should say. Now, there are accumulating evidence that physical activity influences cognitive health in later life, better cognitive function and less cognitive decline in later life. 38% lower risk of dementia. This is very important. So those, they have done 6 years follow-up for these many people, and those exercising more than 3 times a week versus those who were not exercising, and they found that it is very, very beneficial. Now, third thing you should always remember is living with menopause and mental well-being. So you have to mind your mind as well. You should be always a learner. You have to pursue a hobby, continue work, read and converse. So they say that after 40 years, you should have a newer hobby, start learning new things, and start talking also. And mind always your emotions. You should have an extra bonding with your family, friends, participate in the social activity, enjoy conversation, always be happy and contented, always laugh. So laughing is also an exercise. Mind your soul, prayer, meditation, be always positive, and live without expectation. This I always underline, live without expectation. Always you have done your all fulfillment of your life. So live without expectation, so your soul you can nurture. Now, yoga is another thing you can do, that is a myriad of wellness and benefits. If I start speaking of yoga, then it will be another 1 hour. So I just mention here that it also promotes your all the physical, mental, soul, all it nurtures all your body, mind, everything. So there are so many types of yoga, right from Iyengar yoga and all types of yoga, transcendental meditation, everything, whatever suits to you, you can adopt. Now, another thing is sleep hygiene. So as we age, our sleep time gets reduced. So you should always mind your sleep. Go to bed and get up at the same time each day. Sleep in the dark, quiet room in a comfortable temperature. Avoid large meals, exercise, and caffeine. Caffeine and tea you should avoid. Nicotine and liquids 2 hours before sleep. Maintain dim light to get a better sleep. And do meditate before sleeping. So fit at 40, strong at 60, and independent at 80. That should be our motto. The greatest mistake in the treatment of disease is that there are physicians for the body and physicians for the soul, although the two cannot be separated. That says Plato. Always remember these alphabets of nutrition. These always I tell that there are you have to do physical activity, and you have to do yoga, you have to exercise, you have to hydrate, you have to think all things at a time. So these are my few of the references from which I took, and I took some of the photographs, like I took Maninder's photograph from her presentation. So thank you. Thank you, Dr. Rajendra, for association of my committee, and thank you very much for including me in this webinar. Thank you from this is Gol Gumbaz from Bijapur. So I invite all of you to visit once the corona ends. Thank you very much for the opportunity. Thank you very much.
Thank you very much, Dr. Vidya. It is really correct to be said that you had justified to be the chairperson of your committee. As it is also said by Pardesi sir, that you have doing a wonderful job, and today's your talk was wonderfully incorporated everything. Your 3 sutri I liked very much, and about the 5 fingers of the 5 component of the food, it should be taken care of. Very clear cut messages regarding the calcium intake, the vitamin D supplementation, and the physical activity which keeps us physically as well as mentally fit. In a nutshell, a very wonderful talk about the diet, yoga, exercises, present scenario. One message I am having here that Dr. Nandita madam is joining. I think she has joined.
Yes, I'm already there.
She is there.
Oh, wow.
She's there.
Good evening, madam.
Good evening.
And so you can address to everybody, madam. Welcome you in the program.
Sheshan, take off this. Sheshan. Let's have the screen. I think first of all, on behalf of MOGS, I'm really happy that we've Raju, midlife, MOGS, Foxy, you've got it together. Vidya, I think Vidya is very close to MOGS. She
Yes.
just that box would be moved a little bit here, there, and she would be there.
Yes.
Lakshmi.
Amchi Marathi.
Amchi Marathi. Me Marathi.
Lakshmi is Amchi Mulgi only.
Yes.
And Maninder, we'll train you in Marathi. Don't.
No matter, madam, Marathi or Hindi, we all are yours.
Yes. I think fantastic to have everybody on the MOGS platform, and I'm really happy that you all are doing such great work and fantastic talk. I heard Vidya give a superb talk. I'm looking forward to Maninder's. But also before I go away, I want to just tell all of you, especially Maharashtra, that we are having Lakshya Manyata, and we really want you all to register for it. Believe me, in COVID times, you want your staff to be perfect, and we are having actually special training programs during COVID for the staff and all. So it is my sincere request that whoever is watching, please go on our website, Foxy website, and register for Lakshya Manyata in Maharashtra and Manyata all over the rest of India. And I think it's a wonderful program which gives you quality assurance, and it will really give you keep you a niche above all the other hospitals which are not Manyata.
Absolutely.
So thank you very much. And Raju, and Vidya, fantastic job. Please continue. Jyoti, thank you. I think last
Madam,
year.
my college is Lakshya Manyata Prapt. My college is one of the center of excellence for the Lakshya.
Fantastic. And last year also we were with IMS, and I'm happy to see that the collaboration is continuing in the future, and we will really enjoy being together, bringing out different things. I think it's an amazing platform. People are enjoying sitting at home and watching, because otherwise we would be busy getting ready and going for seminars. I'm missing all of you all. Yeah, I can't give you a hug, but hug to everybody. And thank you very much, Raju. Sorry.
Thank you for joining. Thank you for joining in.
Thank you.
It was really, आपने 4 चांद लगा दिया program को.
Really. That is always an Anita's commitment, and I just want to tell as a Manyata assessor, I just assessed Amravati, and it was a wonderful thing. People are joining.
Nandita,
Yeah, Lakshmi.
your initiative and leadership is really commendable. The way you involve others and other organizations, really hats off to you for being inclusive.
Absolutely.
That I always appreciate about you. You are so humble and modest.
Yeah.
God bless you.
I echo your thoughts, Lakshmi. She is a great person. And I know her from close quarters. Really love her.
Very true.
We're all friends eventually. You know,
And it's so nice to see you.
Grow together.
Yeah, exactly.
And all of us are doing pro bono work for people because we love it. We're passionate about it.
Love it.
Imagine Saturday evening, we're all sitting and doing this webinar. I've been on the webinar since 3 p.m. So it's great.
My family is giving me what we are doing.
It's time for a glass of wine also, if those who are interested.
I was suggested last time that whenever now I come, everybody comes with a cup of coffee. Next time, Nandita with a glass of wine.
Yes.
I think the lockdown brings us more closer. Every time we were not able to see Nandita Madam in the program, but we can see now. We can see frequently. So
Thank you,
lockdown
Nandita,
has
for coming.
brought us closure.
I know it's great. Chalo, all the best. And
Thank you.
Thank
you
you.
can take over.
Thank you.
Thanks. Maninder, waiting for your talk. What do you
Mine is a different topic.
Okay, you
Yes.
have
No evidence.
I don't know what I'm wearing below the top. I hope somebody is talking about cosmetic gynecology.
No.
Not in this particular webinar, madam.
We are having one more.
Otherwise, cosmetic gynecology became a part and parcel of all IMS and midlife conferences nowadays.
Gynecology. It's very good for SUI, very good for lubrication, very good for dyspareunia. You know, it has its application. So it's not cosmetic. I should not.
Last year.
It's therapeutic.
Yes. Last year, we have our annual conference of the Menopause Society Raipur. We have kept full portion for this because it should be known to each and everyone.
Okay.
So,
Let's move
Manida
on.
Yeah, I've shared.
Inder is still sharing her thing, so that's why
I have shared now. Why it's not coming?
Can't see your slides, Maninder. Maninder can briefly
Screen
talk
share.
about these issues. You can include these cosmetic things.
Now I have.
No, the lasers and the lasers.
Yes.
Wonderful.
I could have taken that topic actually.
Yes.
Designing lasers and everything.
Maninder, down
I'm coming or not? My screen is not being shared.
below
Ma'am,
your screen.
in the down panel, there is a green button. Yes.
Yes, now you're on. Now
You are
it's
on, madam.
Perfect. We can
Yes.
see you, Maninder.
Start with first. I have to thank Nandita.
little disturbance in the sound, madam. Otherwise,
It's lovely to see her here. Now sound is good.
yeah, now it's better. Yeah.
Okay. So it's lovely to see Nandita here and for her this effort of bringing Foxy and IMS together along with the midlife committee and the food and drugs committee. And I tell you, Rajendra Nagarkoti and Jyoti are my two very, very favorite persons and very close to my heart, both of them. And
Thank you, ma'am.
both of them are doing excellent
Thank you, ma'am.
work in the midlife awareness programs. I never call it menopause because menopause is a negative word. So, and after wonderful talk by the Lakshmi Shrikhande and Vidya Thobi, I'm feeling a little complex now because when I told him, I don't believe in something, so you want me to talk on that. So anyway, I'll be giving the evidence, what is there, menopausal hormone therapy. Do we have something beyond menopause hormone therapy also? Because we have been talking day in and day out about the menopause hormone therapy only, as if that is the only solution available with us. No, we have other therapies also available with us. Now, why this is required is because the women have to spend more than 1/3 of their life in midlife or menopause, because life expectancy is increasing and the menopausal age is same, 46.6 years in the India and all over world 52 years. So this is basically a hypoestrogenic stage. Now that hypoestrogenic stage is affecting whole of the body because estrogen receptors are present all over body. So women do need help, and that was known from a long time when they were realized, when they were called the 7 dwarfs of menopause. They become bitches, they become itching, sweaty, sleepy, bloated, forgetful. Now all those symptoms were there. So that means women needed help. So they started with the extracts of ovaries from the goats even, and anything they could find hand on, they would eat it. But then came the hormonal therapy and we became comfortable. But of course, almost 600 million women were using since 1970, and 1990s abruptly halved after the HR study, and 2000 stabilized during, it decreased almost to nil, and then again came up, and 2010 about 12 million current users are there. But the women population is much more than that. I've already said about 600 women million years. So this was the results of WHI study, which said, okay, it's a taboo to use menopause hormone therapy. You cannot use it. Now, when you go into the relative risk and the absolute risk, of course, the absolute risk was not much there. But there were some glaring things which are still there after when we have declared that menopause hormone therapy is comparatively safe to use. The strokes, DVT, breast cancer, cancer survivals. These are the patients, liver function disorder. And Lakshmi has made my talk very easy, and so has Vidya Thobi. Thank you to both of you. So I can summarize. Now, all of you know that they are the symptoms which are the basically vasomotor symptoms. And out of them, what are bothering most of the women is hot flushes, night sweats, insomnia. And then comes the sexual dysfunction and musculoskeletal disorders and psychological problems are there. Now, these are the quality of life issues. They are not life and death issues. So for that, we should not put our women to risk. But of course, if there are some alternative available, just look into them, whether we have some evidence regarding that or not. So osteoporosis, we can use menopause hormone therapy, but the cost effect involved for so many years, and especially with the retired persons, sometimes it's not very convenient to use, and urogenital symptom. And of course, we cannot give for the coronary heart disease prevention. So that means there have to be some other products where we can be used, diabetes mellitus, depression, thyroid, osteoarthritis, everything. So Vidya has talked very nicely about the lifestyle modifications, but first thing which she talked about was the assessment of the patient. That is very important, and Lakshmi Shrikhande also highlighted on this thing, that first we have to triage our patients and looking upon their past histories, present histories, family history, history of cancers, fractures. We have to look into whether they actually need the menopause hormone therapy, or we can do something else for them, especially if the symptoms are not much, and that even some risk factors are there. So whatever the products the women have been taking for years, and in different ethnicity also, like Chinese, Japanese, they have been using something. Let's learn something from them, whether they can be useful for us or not. So indications for non-hormonal therapy normally remain the cancers or contraindication for menopause hormone therapy, which were highlighted by the Lakshmi Shri Kande. So there are a subset of women who are very severe hot flushes and nothing else can help them, and they do need menopause hormone therapy. But then there are women who are suffering more than this, but they cannot take menopause hormone therapy, and these are the cancer survivors. They are suffering a lot because we have increased their life, but have we increased their quality of life also? So that is very important. Then urogenital syndrome. Do we have other drugs available for the urogenital syndrome and for the prevention of osteoporosis? So this has been taken care of with their very nicely management, therapeutic management, and prevention is the main mantra. Now, I'll just add one thing here, that walking is a good exercise, but as you age, you cannot even walk. You cannot walk if you're not taking care of you because of your joint problems and your sarcopenia, which is settling in. So what we have to do, which nobody is ready to do, is the resistance and weight training, which I am always advocating. So now I have started prescription of exercise on Facebook and various social media. Please join me there, where I've started doing from the Tadasana to Rikshasana and Surya Namaskar, because that is easily can be done by everybody, though it does not have that advantage as of the resistance and weight training, but still. And she has beautifully highlighted about calcium and vitamin D, because that is the basic fuel needed for the bone mass density development. And as we age, she's rightly said that we are losing these elements and we do need their supplements. So, post-women health situation, we started searching for alternatives to menopause hormone therapy. And some of the women, they were already taken that non-hormonal options for menopausal symptoms, but opposed. Now we have to go beyond menopause hormone therapy. Non-pharmacological options are lifestyle changes, complementary and alternative medicine, and pharmacotherapy. Now lifestyle, so Vidya Thobi has covered, so she had made my life work easy. And what are the complementary alternative medicine? Actually, alternative medicine is when instead of menopause hormone therapy, you are using that. That is just like the bioidentical hormones. Now, they don't have randomized controlled trials, so I'm finishing here. Because of their safety issues, we are not using them. Complementary therapies, lots of them have been mentioned, and we'll be just going through that evidence. What is the evidence is in their favor, and then you take your own decisions. So we have already covered this thing about the hot flushes. You have to do lifestyle modifications, fans, layering, and stop smoking, very, very important. And we covered a good webinar with Dr. Alpesh Gandhi on the environmental pollution. I think that was required. But what we have to learn is smoking. We are always saying stop smoking. How of our colleagues have stopped smoking, and how of our younger colleagues are already going into this club of hookahs and the smoke in my hand, with a cigarette in my hand. I felt like a man. So they are also becoming femme fatale. And I think this is the time when they should actually stop it, because preaching is easy, but getting things done is very, very difficult. And weight loss is one of those things which cannot be done easily unless you are completely focused on that. So Vidya had already said how we have to control our calories and how we have to do our exercise. So both things go hand in hand if you have to do weight loss. And these are very important if we think about the coronary heart disease risk or osteoporosis also. We have to do balancing exercises. That's why my social media, femfit.doc. So on the website of SMLM, on the website of FOXY also and IMS, I'll be sharing everywhere, because we all have to look after our women. It's not an organization which can live into it. So already these all things have been covered by Vidya Thobi. So thank you, Vidya, for making my life easy. So complementary and alternative medicine, what is that? Alternative medical systems, homeopathic and Ayurvedic, they are there. But as an allopathic person, we are not allowed to talk about them. Mind-body interactions, energy therapies, manipulation and body-based therapies, biological-based therapies, And why should we bother about these alternative therapies? Because women want them. 25 to 36% of the patients are using this alternative therapy, and 45 to 56%, almost more than the placebo effect. They say, yes, it does help. So 68% of the patients in one study felt that they improved their symptoms. Now, use of CAM is common among many ethnicity, that is Hispanic, Asian, white, Japanese, Chinese. They are using a lot of these alternative therapies. They have been some studies also in these. So we'll just go through those studies. What were those studies in these? Yoga and menopause has been covered. It's a good stretching exercise. It's a good toning up exercise. It's a good balancing exercise also. But as far as the BMD is concerned, it does not increase in BMD. But if done in moderation, it does control your heart flushes. That is very important. Sleep quality is improved. And I tell you, any type of exercise you do, dopamine is released, and it's always helping you a lot. Do anything, but at least do something. That's what I say. So 90 minutes a day, sometimes not feasible. So it has to be 45, 50 or 60 minutes per day. But that prescription of exercise depends upon whether you have to lose weight, you have to strengthen your muscle, or you have to do balancing exercise. So it's a different set of exercises for each indication. So now we are doing actually prescription of exercise. That's why I told Rajendra that I won't be able to talk about exercise here, because we have to give actually demonstration of exercise, and that's what I have been doing from the very beginning now. So placebo effect for the various drugs, whichever the ethnicities are using, that placebo effect is also there for vasomotor symptoms. Because if there are many placebo groups, when they are doing the randomized control trial, in placebos also, if it's 50 or less than 50% advantage there, that is just a placebo effect. So when we are interpreting the results of many complementary medicines also, then the confounding factors are these placebo effect also. So that is why we have to take all these studies with a pinch of salt, and let's see how those are coming. Now, cognitive behavioral therapy has reduced the vasomotor symptoms, even with the history of breast cancer, or with the history of breast cancer without. Reduction in problem rating was from 47 to 52% at 6 and 26 weeks. Reduction in frequency of heart flushes was there. Intensity and frequency 29 to 40%, and in the controls it was just 12 to 22%, and improvements in mood, sleep, and quality of life was there whenever the behavioral cognitive behavioral therapy or CBT was given. So there are other biological based therapies also, and there are other on the counter available products, and lots of them, botanicals and animal derived extracts, vitamins, minerals, fatty acids, amino acid, proteins, probiotics, whole diets, functional foods. You can just take them, but they are not going to improve your vasomotor symptoms. So CAM, menopause management, is phytoestrogens. Now they have been used a lot in the treatment of vasomotor symptoms, hot flushes, soybean, red clover, flaxseed. So even Vidya Thobi had highlighted in her diet pattern. And herbs and antioxidant, lycopene, vitamin E, black cohosh, evening probiotics. So there's a long list: Donquay, St. John's wort, chaste tea, berry. And when I'll come at the end of my evidence, you will see that none of them is useful. So most commonly used are phytoestrogens, red clover is there. Now, hormone therapy, I have already given this background that they have been used estradiol 1923 to 1928, then Premarin came, and then Women's Health Initiative, and we came with the alternative drugs. Now, classification of phytoestrogens, because these are the most commonly used drugs, and people will basically normally ask whether they should be using phytoestrogens or they should not be using phytoestrogens. Now, phytoestrogens are isoflavonoids, which are three groups of phytoestrogens, isoflavonoids, and which is divided into diazine, genistein, and glycine, and cumistine, which are cumistrol, and then lignans, which are antorolactone, and then phytoestrogens. What are they? They are divided into so isoflavones. They are found in legumes, soybeans, soya products, being the major dietary resources. Can I remove this thing because my slides are being covered? Anyway, so lignans are found in high fiber cereals, unrefined grains, and with beans, flaxseed containing the largest amount. And cumistine are found in large quantities in alfalfa, clover sprouts, less amounts in split peas, lima beans, and pinto beans. So now what is the evidence? Phytoestrogens, how they are acting? They are derived from the edible plants and they are acting through estrogen receptors. Like I told you, even menopause hormone therapy is acting through estrogen receptors only. Basically, these products, they act on estrogen receptor, beta receptors, and they don't act on the alpha receptors. Now, alpha receptors are present in the breast and the uterus and the ovaries. So that means they don't have any carcinogenic effect. And when you compare the potency of the estradiol to cumistrol, genistein, diazine, you find that they are very, very weak estrogenic, 0.2, 0.08 as compared to 100 of the estradiol. So there are two different types of receptors, alpha and beta. And beta receptors are present in CVS, bone, ovary, brain, and urogenital tract. And alpha are present in the genital organs, basically breast, uterus, brain, and ovary. The estrogen receptor beta, they modulate the effect of estrogen receptor alpha in the cells where both the receptors are present. And cellular sensitivity to E2 at low concentration is reduced in cells with both the receptors. So negative effects are gone. So these receptors, then there are the SERMs, because many of these phytoestrogens act like SERMs also, like they have a, I can't see my slide actually completely. Can I change the screen? No, I won't be able to see it. Okay, anyway. So agonist effect will be there when they have the same effect as the estrogens, and they have, when they are opposite to that, the antagonist effect is there, and in that is involved the co-pressor proteins and the co-activators are also there. Then there are effect through genomic and non-genomic pathways. Now genomic act through the nuclear receptors, and the membranous receptors are non-genomic, but that is a faster effect. So if the drugs are having a non-genomic effect, then they will be having a quicker effect. So this is how the mechanism of action of phytoestrogens is, that their binding affinity of the phytoestrogen is 100 to 1000 times less than estradiol, and they bind both to alpha and beta, but mainly to beta more, and breast stimulation is suppressed them. So that is one advantage. Phytoestrogens may act as endocrine disruptors. This is according to their pharmacology. They may increase SHBG and alter free hormone levels, may increase cycle lengths and suppress LH and FSH, but they also inhibit tumor growth factors such as protein tyrosine kinase. So tumorigenesis inhibited, phytoestrogens may inhibit vascular endothelial growth factors, and phytoestrogens have general antioxidant properties. That is very important. And resveratrol, which is found in the grapes and red wine, has been shown to lower levels of cholesterol, blood sugar, and insulin. So these are the how these are acting. And when you compare the potency, I've already shared this slide with all of you. So food contents of the isoflavones are two, that are genistein and diazine, and they are found in Bengal gram, soybeans, chickpeas. I think I've already covered it. And lignans are enterolactone and enterodiol are found in flaxseed, lentils, grains, fruits, and vegetables. Now, regional differences in dietary protein sources are there, because in Asia, we are taking more of soya sprouts, tofu, and Central America, more of tempeh, miso, and beans. That I'll show you the slide how from soya, these products are made. Mediterranean, lentils, peas, chickpeas, and Western diet has more of meat, eggs, and dairy. And where average intake of isoflavones, which is there in these populations, if we look into that, then Japan has a very high intake, and that intake is from the very beginning. So 38.2, China 10.6, India is just 1.2, USA is 0.012, Spain is 0.01, UK is 0.006. So that is how you see that the routine intake of isoflavones is like this. So phytoestrogen, some facts are there that the variation in plasma levels are seen in the individuals receiving the same dose of isoflavones. Variability in absorption leads to differences in their bioavailability, and absorption is influenced by the intestinal flora of each individual, and the ability of individual to produce a substance equal is different. Caucasians have just 20 to 30%, of Asians can convert 50 to 60%, and this is the active compound which acts actually, and safety of isoflavones at specific amounts has not been established. So there is no dose relationship of these isoflavones to their effect on the body. So most of the studies say that we should not give more than 40 to 80 milligram or 40 to 50 milligram per day are given, but there is no dose scheduling which has been done. So soya protein is considered a good protein, but how do we increase that protein intake? Now, if dietary isoflavones reduce the incidence of menopausal symptoms, then they have been related to isoflavone excretion nanomole per day. So Japan, you see that the excretion of these in urine is very high. That is why reduction in the hot flushes is there. Singapore, China, same is there. But in Europe, excretion is very less. And so the reduction in hot flushes is very less in Malaysia. So that means reduction in hot flushes has some other factors also. So just tell you how the soya derivatives are made. When you do the fermentation, then only tempeh and soya paste is there, which is high in proteins. Isoflavones are high in isoflavones, soybean, soya flour, and soya protein. So with hot water, you can make the soya milk, but that soya milk doesn't have that much. You take out the oil, they take the soya flour and make the soya concentrate and proteins, and they are very high in the isoflavone contents. So vasomotor symptoms. Now, what are the studies saying? Now look into it. A study by, this is reduction similar in low dose HRT, 3 recent study. Mixture of 60 milligram isoflavone, 30 milligram lignin found a significant reduction in hot flushes, but the study is very small, 80. And when there was a simple, large randomized control trial, soya isoflavones at 200 milligram did not difference between no difference in the intensity and frequency of the hot flushes were there. Same way the other trials have shown that though some trials have shown positive effects, some trials have not shown any positive effect also. So where do we stand? At the end of all these meta-analysis, and the large SWAN study did not find any advantage. A meta-analysis found some advantage. Red clover and isoflavones studies have been done, and largest randomized control trial for red clover isoflavone found no difference in hot flushes. This is how, as compared to the placebo, there is no difference in the red clover, different dose schedule is there. So Cochrane summary, what does it say about the vasomotor symptoms and phytoestrogens? Dietary soya, no evidence diet high in soya had any effect on hot flushes. Soya extract, no evidence. Genistein doses of 30 to 60 milligram daily can reduce the hot flush frequency as compared to the placebo effect. Equal, that does reduce it because that is the active component, 61% as compared to placebo of 45%. Safety, no effect on endometrium has been seen, and mixed effect on the vaginal cytology is seen. So summary, no conclusive evidence that they show a beneficial effect on the vasomotor symptom phytoestrogens, with the exception of genistein, and 20 to 30% of the Caucasian only as compared to 50 to 60% have necessary gut microflora to convert diadesin to equal. So that goes our dietary isoflavones. So phytoestrogens and vaginal atrophy given for a longer time, placebo control 90 milligram soya isoflavones can found some improvement in the as compared to placebo in the vaginal atrophy or vaginal urogenital symptoms. Cardiovascular have minimum effect of reduced LDC by 3% has been found, but they say any effect of soya on cardiovascular health would be minimal. Bone health, Again, they have not found any fracture data which helps in that. Yes, breast cancer, they have been found, at least they don't increase the incidence of the breast cancer. They are because active through the estrogen receptor beta, which are not present there. So they don't have an agonist effect there. And non-genomic effect include anti-proliferative effect, tyrosine kinase inhibition, steroid hormones, induction of apoptosis of abnormal cells, and reduction of circulating and intra-breast concentrations. So effects of phytoestrogen on breast cells in vitro, genistein, resveratrol, quercetin, they have no bad effect on the breast cells, but they do inhibit the growth of malignant cells. Epidemiological hypothesis that phytoestrogen had anti-proliferative effect at low concentration by estrogen receptor. And the breast.
Would you wind up in about few?
Yes, so all these problems,
Yes.
So all these studies have shown that these trials are, what is the problem? These trials are too small and too short. Many trials have significant confounding variables. Factors other than phytoestrogens may be implicated. For example, diet high in phytoestrogens and low in animal fats. And these ethnicities, they have been using these diets from the very beginning. So they have been using, then only they have been found to be effective. Vitamin E, black cohosh, botanicals, they don't have any role to play. And non-hormonal pharmacotherapy is of course helping. That is the paroxetine, fluoxetine, SSRIs, SNRIs, venlafaxine, desvenlafaxine, even in the cancer survivor patient, and anti-epileptics like gabapentin and pregabalin can be given, but paroxetine and fluoxetine cannot be given when you are giving the tamoxifen. That is very important. Otherwise, dose is 7.5 milligram, and gabapentin can be given in 900 milligram per day. So management of hot flushes, simple lifestyle changes are very much required. Then paroxetine, gabapentin, and the new drug has come up. Cognitive behavioral therapy help. Acupuncture as compared to sham is helping. Relaxation therapy is helping. And new molecule oxybutynin has come, which in a doses of 2.5 milligram per BD or 5 milligram is effective in controlling the hot flushes. Side effects are minimum like any anticholinergic drug. So local therapies are available and they can be used, of course, all the lubricants and moisturizers, and they can help in the vaginal atrophy. So future directions are that given the mindset of Indian consumer and the physicians recommend that herbs and phytoestrogens should not be set aside. And we have to do more work on that. So because every civilization, physicians have emphasized the importance of good nourishing diet to eat what is locally available. So we should be working more on whatever is available, and we should be doing more of randomized control trial. Because if necessity is the mother of invention, that's discontent is the father of progress also. So for that progress, we have to work more. So thank you very much for guiding them, because this was a topic out of blue which I have talked about.
Thank you, madam. Very extensive talk. Thank you very much.
Thank you, Manindar madam. Raipur Menopause Society remembers you very fondly since your presidency, and you have been here and given many things to the society. You are icon of energy and the enthusiasm. And today your talk was about something other than the MHT. MHT is not only single thing which can give benefit to the patients. There are so many patients who cannot take it, or there are many other medications which can give them a lot of help. So thank you very much for your very extensive, elaborate talk with the lot of review of the literature. I think we should be going with listening to Dr. Rajendra Pardesi, because time is also running very short. So may I sincerely request Dr. Pardesi sir to start his talk about the osteoporosis prevention and management. Welcome, sir.
Sir, you are muted.
Sir, your mic is muted. In the down panel of the screen, you can see the, yeah.
Yes.
Yes, we are able to see your slides. Your screen is already shared, sir.
Thank you, Dr. Jyoti. Thank you, Dr. Rajendra Nagarkatti.
Thank you, sir.
Is giving justice to this midlife management committee. Thank you so much.
Thank you,
Yeah,
sir.
I very much agree to this, sir.
Yes. And even thank you, Dr. Lakshmi, Dr. Vidya, and Dr. Maninder. They have covered many preventive part of my talk so that I can concentrate on the management only, right? And Dr. Maninder, she is as usual excellent. She is the hardcore practitioner. She has covered a lot. So prevention and management of osteoporosis. As you know, a systemic skeletal disease characterized by low bone mass and microarchitectural deterioration with a consequent increase in bone fragility with susceptibility to fracture. And mainly, it's not an inevitable part of aging. Many people are saying, no, umar se to ho jata hai. It is preventable. So it is vital that all of us, of all ages, start taking care of our bones now before it's too late. It's preventable and treatable. As Dr. Lakshmi has elaborated the role of estrogen and the skeletal system, just I want to highlight acute estrogen deficiency. And there is a accidental bone loss. Estrogen and osteoporosis. This effect of estrogen is always there. If estrogen lowers down, then started osteoporosis. So see, these are the figures, estrogen and the skeletal system, and the annual incidence of fractures in USA due to the osteoporosis is too much. What are the risk factors? As you know, I don't want to highlight. These are the risk factors of osteoporosis. We have already discussed. You know BMD test. What is BMD test? And these are the different methods of BMD test. But in these methods, DEXA is gold standard. Just I want to share my experience. When I installed GE's DEXA scanner with my private hospital. So they told, congratulations, doctor, you are the only one from other than Mumbai, means rest of the Maharashtra. So it's not the congratulation. I felt sad that no one is practicing osteoporosis. So it's a very sad thing. We are referring our patient to orthopedician or endocrinologist. Why should we try? Because postmenopausal osteoporosis is very common. And I think we are neglecting. See, this is the diagnosis of osteoporosis. All you know, the levels of T-score. The 4 major goals in the treatment of osteoporosis, prevention of fracture is very important, and stabilizing the bone mass or achieve increased bone mass, relieve symptoms of fractures, and maximize physical function. These 4 goals are very important. Lifestyle changes from the base of the prevention and management pyramid, including adequate calcium and vitamin D intake, physical activity, and fall prevention. And the second level includes assessing the treating secondary causes. The third level includes pharmacological intervention to improve bone density and reduce the risk factor. The 3 levels has been suggested by US surgeon. If pharmacological therapy is indicated, FDA approved options are estrogen, bisphosphonates, calcitonin, and PTS. These are the main. The therapy includes physical and chemical. As you know, physical therapy is physiotherapy, orthopedics. Chemical includes anti-resorptive drugs and hormone replacement therapy. I think hormone replacement therapy has been covered a lot. Even physiotherapy also, exercises also. In osteoporosis, now we'll directly go to the management. Anti-resorptive drugs, they decrease the imbalance between the bone resorption and bone formation, decreasing the overall rate of bone turnover, or by both. These are the calcium and vitamin D metabolites, calcitonin, gonadal steroids. Hormone replacement therapy for women within 10 years from the menopause. The details of that already has been discussed. It's the contraindications and indications, but it is useful. Anti-resorptive agents. Estrogen acts directly on the bone cells through high affinity estrogen receptors. Exact mechanism not known. At menopause, when estrogen level decreases, bone turnover increases. As I told you earlier, estrogen is very important. Its effect on skeletal already discussed. And estrogen with a greater increase in bone resorption than bone formation. Around 33% of bone loss in women may be attributed to menopause. Calcium. If amount of absorbed calcium is insufficient to offset the obligatory losses in urine and feces, bone loss ensues. Post-menopausal women, calcium supplementation may decrease bone loss because only calcium will not be sufficient after post-menopausal osteoporosis. Calcitonin. Calcitonin inhibits bone resorption and has analgesic properties. Parenteral calcitonin increases vertebral bone mass with post-menopausal osteoporosis. Intranasal calcitonin therapy retards the post-menopausal bone loss. There are disadvantages also. Bisphosphonate. Bisphosphonates are very important, like etidronate. Anabolic steroids. They increase bone mass in women. It stimulates bone formation. Calcitriol. Active vitamin D metabolite or its analog alpha calcidiol. It's very important. It acts by increasing calcium absorption, but may also stimulate the function of osteoblasts. Improves calcium balance and decreases the rate of fracture. Transient hypercalciuria and hypercalcemia. Prevention is very important. Previous three speakers already highlighted the role of calcium, calcium supplement, vitamin D metabolite, and their absorption. Parathyroid functions, all has been described. See, the important is corticosteroid-induced osteoporosis. How it can be prevented. Corticosteroid cause sodium retention and calcium and potassium depletion. Prolonged corticosteroid therapy leads to calcium depletion, resulting in osteoporosis. See, these are the indications for prescribing corticosteroids. There are many diseases like bronchial asthma, rheumatoid arthritis, colitis, organ transplantation, SLE, nephrotic syndrome, autoimmune disease, malignancies, cerebral edema. So we have to prescribe, but care should be taken. Vitamin D preparations are not recommended in steroid-induced osteoporosis. Vitamin D is not at all useful. It is to be administered only in substrate deficiency condition like lack of UV sunlight, inadequate vitamin D diet. Combined therapy of vitamin D plus calcium is not effective in steroid-induced osteoporosis. Then what will be the alternative? The only answer to this problem is alpha D3, alpha calcidol 0.25 microgram. Alpha D3 with its specific action prevents steroid-induced osteoporosis. Why I highlighted is because steroid-induced osteoporosis is nowadays very common with increasing pollution, allergy, asthma, all these. Increased activation of bone growth factors and bone matrix protein which are inhibited by steroids. Alpha D3 action is very important. It inhibits the synthesis and release of parathormones, thus preventing bone resorption, increased trabecular bone volume, improves gastrointestinal calcium absorption, useful in transplant surgery and bowel diseases, vertebral bone loss prevented by calcitriol. Hormone replacement therapy is very important. As Dr. Lakshmi also stated, HRT consists of estrogen alone or combined with progesterone. Additional benefits of estrogen are lower risk of ischemic heart disease and treatment of direct menopausal symptoms. And care should be taken because increased risk of endometrial and breast cancer, non-compliance. Patches are already available, all detailed by Dr. Lakshmi. These are the other related diseases during this, that is hypocalcemia, hypercalcemia. Then phosphates. Phosphates are also very important. It's a structural and functional component of bone and teeth. That's why in osteoporosis, phosphates is very important. About 85% of phosphate is present in bone as calcium phosphate salts. Phosphate is principally an intracellular electrolyte. Pain management in osteoporosis is subjective. Each and every person you have to supplement any of these drugs, then I will directly jump to the newer modalities. You will be giving all bisphosphonates, estrogens, calcium, and vitamin D, alpha calcium, now new modalities. Denosumab. Denosumab is a RANKL inhibitor. It's a human monoclonal antibody. Denosumab is given every 6 months. It increases bone density and reduces the incidence of spine and non-spine fractures, including hip fractures. I have tried many times. It's really very useful. Now recently, romosozumab for the treatment of osteoporosis. It's a recent drug. It's a specific inhibitor of sclerostin. It's a unique approach to the therapy of postmenopausal osteoporosis and related disorders. The elucidation of sclerostin deficiency as the molecular defect of syndromes of high bone mass with normal quality and the pivotal role of sclerostin as a mediator of osteoblastic activity and bone formation, provided the platform for the evaluation of inhibitors of sclerostin to activate bone formation. This review will highlight the result of those studies and describe the current status of romosozumab as a potential therapy for osteoporosis. No doubt, it's not available now in India. It's very costly. Nowadays, 50,000 per month is the treatment, but slowly out of patent, then it will also come in India. It's a really fantastic formation and resorption. Both will be acting. Then severe osteoporosis with fracture risk. I had presented my own study of intravenous zoledronic acid plus injection denosumab for 3 years in severe osteoporosis with fracture risk in AICUG 2018 Bhubaneswar. No doubt, data was small size, limitation due to the cost of the drugs, but result is encouraging. I got best paper award in that AICUG for this. And now many people, they are asking about this study. Calcium recommendation, as all know, 1200 milligram daily, up to 1500 also postmenopausal women who are not receiving estrogen, and 1200 to 1500 milligram daily, pregnant and nursing mothers. There are reports, if mother will divide of calcium and vitamin D, then fetus will be having chances of osteoporosis in the early ages. These are the studies. Nutrition and management is the important part in the prevention of osteoporosis. Dr. Vidya and Dr. Maninder has highlighted very nicely. Nutrition and bone, muscle and joint health are closely related. Two of the most important nutrients are calcium and vitamin D. Calcium is a major building block of bone tissue. Vitamin D is key at assist your body to absorb calcium. The two will go hand in hand. There are a number of foods, nutrients and vitamins besides calcium and vitamin D that helps to prevent osteoporosis and contribute to bone, muscle and joint health, including protein, fruits, vegetables and other vitamins and minerals. As Dr. Maninder highlighted the role of exercise, even Vidya, it's very important. Mental and physical along with social health together forms the health. Exercise plays very important role in maintaining our good health. Morning exercise increases production of endorphin, ultimately causes charged feeling in good manner. Morning walk, yoga, pranayam can be tried. It really works. As Dr. Maninder told, no doubt yoga doesn't increase BMD, but it improves your mood to exercise, and exercise definitely helps. Exercise is important in prevention of osteoporosis. The dimensions of physical activity, frequency, intensity, time and type each have an effect on the health outcome. Studies suggest that the type of physical activity carried out is by far and most important dimension that affects bone. While virtually all physical activity reduces the risk of cardiovascular disease, swimming, cycling will rarely augment bone mineral density. With increasing age, however, the emphasis of exercise will switch gradually from bone loading to muscle loading. It's very important. Bone loading to muscle loading in order to improve parameters of muscle function. such as strength and coordination. This also holds true for patients with advanced osteoporosis, characterized by multiple fractures and severely reduced bone mineral density, to help them avoid further fractures, prevent falls, and to facilitate daily activities. Because only running is not important. All other exercise, abs and all those, as Dr. Maninder told, is very important, because muscle power is very important afterwards. These are the recommendations for children and adolescents, because from childhood, if we will take care, we can prevent osteoporosis. Make a lifelong commitment to physical activity and exercise. In terms of bone health, weight-bearing activities such as basketball, volleyball, and gymnastics are most effective than weight-supported activities such as swimming and cycling. Intense daily activity is more effective than prolonged activity carried out infrequently. Perform activity that will increase muscle strength. As I told you, it's very important, such as running, hopping, or skipping games. Select activities that work all muscle groups like gymnastics. Avoid immobilization and perform short weight-bearing movements if confined to bed. Eat a well-balanced diet that is rich in calcium and protein to promote normal growth and puberty, as well as regular menses for girls. These are the recommendations for young adults and premenopausal women. After puberty, BMD is not easily augmented. The main role of exercise in young adults and premenopausal women, therefore, is to maintain BMD rather than to increase it. Nevertheless, high-intensity exercises can lead to modest bone accrual in targeted areas. Even small increases in bone mineral may significantly reduce the risk of fracture in later life. These are the recommendations for adults and premenopausal women. At least warm up for 15 minutes, high impact jump for 20 minutes, and stretching and non-impact activities for 15 minutes, cool down for 10 minutes. 1 hour should be given for this. And these are recommendations for postmenopausal women. To increase bone mass is important, and they should give 60 to 70 minutes, and to home training sessions is for 4 days per week, and to 2 days for home training sessions of 20 minutes each. That means they have to spend 60 to 70 minutes, at least 4 days a week. Now, let us see osteoporosis and asthma. How to prevent? What's the relationship? In a study, conclusion is that demonstrate that the osteoporosis is more prevalent in patients with SCVS, with asthma, COPD syndrome, than in those with asthma, and that the diagnosis of SCOS itself rather than asthma could be risk factor for low BMD. Patients with SCOS, particularly aged and lean women, should be more carefully monitored for osteoporosis compared to patients with asthma. Breastfeeding. The relation of breastfeeding and osteoporosis. Breastfeeding appears to reduce the mother's risk of developing osteoporosis in later years. It's very important. This risk for a woman who did not breastfeed her baby was 4 times higher. Although mother experienced bone mineral loss during breastfeed, their mineral density is replenished and even increased after lactation. It's very important study. Now, as I told you, yoga and exercise, Dr. Maninder, he has highlighted very nice. Important of yoga to improve your mood, to do exercises. See, these are some exercises I will highlight. He has narrated many Tadasana and all other also. Now we are lagging behind of time. See, there are many exercises, many yogas, those who are suitable, those which are suitable to you, that should be done. In the management, now these are the, so what are the other factors in the management part? So our investigations are important. Yes, investigations are the part of management. Just I want to highlight. What are the basic investigations? So for primary cases, CBC to rule out anemia, serum calcium, serum phosphate, serum alkaline phosphate, and serum vitamin D, Then other cases, serum creatinine for renal impairment, serum magnesium, serum testosterone, because in younger patients, younger men even, low bone density will be happen. Serum protein electrophoresis to identify multiple myeloma, then anti-gliadin and anti-endomycel antibodies to identify celiac diseases. These are the rare causes of osteoporosis. This is in the management part. These investigations are very important. Like serum tryptase and uranium methylhistamine to identify mastocytosis, bone marrow biopsy to rule out hematological disorders, LFT to liver disorders, and thyroid functions, TSH. There are many other investigations. Two secondary causes to rule out secondary causes, 24 hours urine calcium level to assess hypercalciuria, PTS level for hyperparathyroidism. Because this comes in management. Even if you don't have BMD machine or DEXA machine, no need. These investigations are a part of management. There are biochemical markers. Just I wish to highlight biochemical markers of bone turnover. You can easily do that are easily available. Some serum markers for bone formation. They are bone specific alkaline phosphatase, osteocalcin, then carboxy terminal peptide of type 1 collagen, amino peptide propeptide of type 1 collagen, that PINP, urinary markers of bone resorption, hydroxyproline, then free and total pyridilones, and N-telopeptide of collagen cross-links, NTX, also C-telopeptide of collagen cross-links of CTX. There are many, these we should add in our management part. So this is the important. If you don't, the people are telling, no, we don't have BMD, DEXA, or even ultrasono. But even if we will do these investigations, that will easy to diagnose and to treat the osteoporosis. We met these 3 young ladies at Rohtang Pass. See their real enthusiasm. And I don't think they are having osteoporosis or menopause. They are enjoying. Thank you. Thank you so much. Thank you, Dr. Rajendra Nagarkatti sir, Chairperson Midlife Management Committee. He is giving really justice. Dr. Manindra Rahuja, she is a hardcore practitioner, not a hardcore menopause practitioner, but I think she is a hardcore menopause caretaker. Thank you, Vidya, Lakshmi, and Jyoti, and Dr. Nandita. Thank you so much.
Thank you, sir.
Thank you so much, sir. Thank you so much. And you have very rightly commented about each and everybody, but I will like to comment here that you have done justice to this topic, which is a very, very big topic, osteoporosis, covering in a small lecture is really very difficult one. You have escaped all those things which everybody used to talk about osteoporosis in each and every talk. You have covered those aspects which are usually less talked about, and that was really very good. You have even talked about the bone markers and the newer medications which are very good and very effective for the management of the osteoporosis. So people should know at least that though the bone markers are not very important for the routine this thing, but for the management and follow up of the effect of the medication is important. So we should be knowing all about that. You have talked about the denosumab, which is really a very good drug. Romosozumab, I don't know, sir, whether it is available here or not.
No, it's not available in
It's
India.
not available in India.
And now it is patented, and more than 50,000 per month it will cost. So it's just not possible in India. But out of patent, then that cost will reduce.
It is available now. I think it's available.
Available. What will be the cost?
Because on net you can go and get everything from the net now. There's nothing like because it's not available. You can order it, but of course it's costly. It's very costly. 15,000, around 15,000 one dose is costing.
But see, if it will be out of patent, then it will so. Even with zoledronic acid, when we used to use Zometa, that would have been cost 21,000 previously. Now it's 3,000, maximum 3 to 5,000.
Once we create the market, the rate will come down.
Yeah,
Exactly.
that's good that things are at least available. And when the larger number of the people will be using, the cost will definitely come down, and most of the people will be
I
benefited.
have told Dr. Rajinder Singh Pardesi when I was the vice president. Do you remember you had presented your report as a chairperson? And I told him, if you have to do osteoporosis assessment, don't do the ultrasound of the heel, but do the DEXA scan. And he bought the DEXA scan.
I am doing DEXA scan in my private practice, my hospital. I am having my own DEXA.
So now we have more of machines of DEXA scan, which we didn't have previously.
Sir has got a machine and he's doing for many poor patients. He's doing free of charge.
I know he's doing excellent work.
Excellent work there.
Told me at that time, why did you point out? Maybe we should always point out the right things.
Yes, yes.
Raju sir, I must say that many of the people are listening very carefully, and they are putting their questions continuously.
Yeah, you can go. You can start, Jyoti. You can start discussing their questions.
Yeah.
I'm having
them
some
yourself
questions.
also, or you can just put it up to the panelists.
I think all the panelists, I can see Rajendra sir, Maninder madam, both are there.
Vidya madam is also there. Vidya madam
is also there.
Everybody is there.
I'm happy to share that there are many questions, and Dr. DPS Kamala has raised the question that in natural menopause, hormone supplementation is essential if the patient is asymptomatic. I think that question is very well answered in the Lakshmi Madam's talk, that asymptomatic patients do not need any kind of menopausal hormone therapy or management. Yes, lifestyle management and good diet, exercise, and yoga should always be a part.
Because MHT is not for prevention of comorbidities.
Yes. She has also asked about the phytoestrogens, and madam has cleared out everything about phytoestrogens. But
I just wanted to raise a point here that I think in some instances phytoestrogens do help, and even the alternative therapies. This black cohosh also is a drug which has very good actions, and it is a herb which can be used to prevent perimenopausal symptoms, particularly hot flushes also, and even the vaginal dryness can be treated. The product by the name of remifenin, which I have used in a dosage of twice a day in many patients, especially if they are beyond 60, where generally we don't prefer to use MHT. So I feel that is these alternative drugs also do have a place.
Yeah, my submission is here that
the recommendations of the International Menopause Society, which I had presented.
Yes, madam. Yes, madam. Correct. Maybe it may be to some extent as a placebo.
One submission is here that they have said that there is no conclusive conclusion, but they have not said that they are harmful. So there is no problem if the patient is willing to.
Yes.
Hello.
That's what I said. We should do more studies on that.
I wish to add one thing for phytoestrogens. See, there are molecules, as Dr. Rajendra told about the black cohosh and all remifenin, they are really good. And many molecules, they registered as nutraceuticals. There are no side effects. Even some, I used DT56A, it's a really good molecule. That Femarelli was named. There are two or three companies. And I had participated in their study. Femarelli.
Yeah.
So it's a really good molecule, and there are good results, because there are people there, no, there is no effect. But phytoestrogen, see, the HRT acting directly on the endometrium, where they should not act after menopause. Means they shouldn't miss. There are side effects. But simple thing is, these phytoestrogens act on the system without replenishing the endometrium. They are acting without replenishing the endometrium. That's why they are advantageous.
In a natural way.
Natural way.
I want to clarify one thing here.
Yes.
That when I presented the pharmacological action, they have a good action because they are acting on the beta receptors. So they don't have any carcinogenic effect. That is there.
Correct.
But what is not so far clarified by these studies is that how much effect they are having as compared to the placebo.
Yeah, it is
That
not
is so
quantified.
because we have not done the good work on them. We have to clearly come out with a dosage schedule, and since when it should be started. Like exercise, it has to be started from the very beginning. If you start
Correct.
doing it later on, it's not going to be effective. Same way, phytoestrogens, when they are included in the diets of the like Japanese and Chinese from the very beginning, then they are really effective. In those cases, they are reducing the incidence of cancer also, hot flushes also, osteoporosis also.
Yes.
Thanks,
They
madam,
are used
for
Absolutely
the
right,
way
ma'am.
we are using them.
thanks, ma'am, for answer for the very clear-cut message on this. And there is one more question by Dr. Kamala only, that she wanted to say that Premarin was used earlier, can be used in surgical menopause in presence of uterus, estrogen, whether the withdrawal bleeding will be there. So I think she is asking about the vaginal Premarin, or I don't know about
I think
the
so. Yeah.
oral, but
Premarin cream is available that can be used vaginally.
so
And
in
tablets
vaginal,
are-
there is no chances of the withdrawal bleeding because it do not act directly there. So this question is very clear. And one more question: how come common rural women P4 and above are working? As they were in adulthood, for them menopause is same as their reproductive age group. Can we take them in comparison with the urban getting mature gracefully? Are these diets or physical work making all the difference? Now, this is a question from Dr. Urmil Vadhavan. She wanted to compare the patient of the rural setting, a multipara, with an urban,
This because
a well-planned.
urban women and rural women, their lifestyle is totally different. And we did here one study there. They eat that flaxseed ka chutney, whatever their diet improves. They eat lot many vegetables and they exercise. They have got so much work to do. So definitely there is a difference. And they might be there might be a calcium deficiency, no doubt, but otherwise aging does make difference. I have seen the difference of aging in the urban population as well as rural population. Definitely there is a difference.
There are two different set of populations. I think you just can't compare if you are planning a study. Because it will be totally
About the
biased
treatment
study.
and
Can't have similar parameters.
Better to incorporate that lifestyle. Better to
Yes.
get incorporate
Yes.
that lifestyle and leave the wrong lifestyle part.
My favorite slide used to be that two ladies with a viper and a stick. You remember that slide?
Dr. Archana Khurana asked how to keep your joints healthy after menopause. I think that has been very well answered by most of the speakers.
Yes.
So, yeah.
One more important question.
Yoga.
Please
Start
tell
with yoga.
how
and go
long?
Yes, madam. Start with yoga.
Start with yoga. Simple exercises I am starting with now, like Tadasana and Surya Namaskar. And then slowly move on to the lunges and squats, and then the resistance and weight training. And you will definitely improve. That is my guarantee.
Wonderful advice. Wonderful advice.
Just looking
Another
at you
question.
with confidence itself is enough.
Yeah, definitely. That's why I put her slides.
Dr.
I am
Pragati.
putting on the Facebook now videos. I am putting up. 21st June is anyway yoga day. So all of you put your exercise videos on my Facebook profile.
No, you
Yes, ma'am.
conduct
Sure.
a Zoom meeting on that.
I am conducting. I am showing my videos there.
Yeah.
I am putting up my own videos there now. Just to
Dr.
show
Pragati
exactly
from
how the steps
Nagpur.
are.
May I ask one question, madam? Dr. Pragati from Nagpur wanted to know, please tell how long to use Tibolone. Tibolone.
Tibolone.
How long to use?
I'll answer.
Yeah, you can.
Yes, yes.
Please, anybody.
Tibolone
Yes.
is a steer. Tibolone is a steer which has an estrogenic effect, progesterogenic effect, and androgenic effect also. It can be given for the hot flushes, especially. It does not cause the increased incidence of breast cancer. But the only thing is that if the patient had breast cancer, then recurrence is more common. So in those cases, it cannot be given. But for increasing bone mass density, where the osteoporosis risk is there and hot flushes is there, it can be given. So that is very good. And how long to give is basically with all the hormone therapies, depends upon the indication why we are giving. If it's given for the hot flushes, then it will be given for a shorter period, and when the patients improve, it can be tapered off. But mostly I know it increases libido also. That is very, very positive effect.
That's a very positive, yes.
Patients who actually start taking it, they get hooked onto it and they don't want to leave it. That is the situation. But anyway, with proper follow-up, you can always give these things. Proper follow-up is mammography and lipid profile.
What is the standard dose, madam? Normally, how much of what is the dose that you should?
2.5.
Okay.
Few of the studies also suggested that 1.25 is also effective, but the standard dose is 2.5.
Even 1.25
We can start with the
are also
lowest
there.
dose.
And in those patients where there is a past history of breast cancer, for hot flushes, you can also use the SSRIs and the SNRIs.
That I given the dose also.
Yes.
7.5
milligram is the paroxetine. Gabapentin is the 900 milligram per day.
Yes.
And paroxetine is FDA.
This was just for additional this to
FDA approved, but if there is patient is on tamoxifen, then you cannot give paroxetine. That is very important. In those cases, then you have to give duloxi, which I knew duloxetine. Given the new molecule, which can be given 2.5 milligram daily or BD. That's a good oxybutynin. Oxybutynin.
Duloxetine is for SUI. Yes.
No, sorry. Oxybutynin because it also has an effect on urinary system.
Yes, ma'am.
Lakshmi, madam. Next question for you. A postmenopausal lady with bleeding PB for 1 day only. USG shows normal uterus with ET 6 millimeter. What next? Dr. Latha R has asked this to you.
Because the cutoff values for postmenopausal woman is 3 to 5 millimeter. So I think 5 millimeter is the highest, and she's showing 6 millimeter. She needs further evaluation in the form of endometrial sampling to rule out the carcinoma.
Madam, there are. I want to say something here. If she is very old postmenopausal lady, like postmenopause after 5 years or 10 years, then the 6 millimeter is important, and it is important whether even if the rest of the endometrium is thin, but a focal thickening somewhere is there, it is important to take the biopsy. But if the patient is recently postmenopausal and she is just having 6 millimeter of endometrium and only 1 day bleeding, not a long time, so it can happen. There we can explain that patient to be under follow-up, and then the endometrial biopsy can be avoided, because many studies and the larger metadata are saying that up to the 8 millimeter, if the patient is not having is within the 5 years of the menopause, we can wait and watch, and we can, but the proper follow-up is very important.
That is necessary.
Tamoxifen patient is having more of endometrial thickness.
Pardon, ma'am?
Tamoxifen patients will be having more endometrial thickness.
Yes, the Indian menopause.
Even then 6 to 7 mm is considered normal.
Yes.
It's the eco texture of the endometrium, as you said, is very, very important.
Very, very important. Yes. So there are the guidelines from the Indian Menopause Society. They have very well summarized in a tabulated, charted form, that very clearly saying in which patients it is important to do it and in which patient we can wait and watch. The another question, a 30-year-old lady with ovarian tumor with raised CA125 with enlarged iliac lymph nodes. I think she must be some patient of hers. undergoing total abdominal hysterectomy with bilateral salpingo-oophorectomy. Should we start hormone therapy and when? A young lady with an ovarian tumor with
She's
raised
talking about surgical
CA125.
menopause, when to start. Yes.
Yeah. Yes.
And actually, it's related to ovarian cancer. Now, ovarian cancer, one is the serous mucinous, and one is the borderline tumors. I think those are, because I just don't remember, those are the cancers where we cannot give menopause hormone therapy because the recurrence has been shown to be increasing with them, hormone therapy. Otherwise, other tumors we can give.
And in this particular patient, the enlarged iliac lymph nodes are also present. So we have to see that what is the etiology behind
that. That is the extent of the disease now. That's the extent of the disease, I think.
Okay, so she can be having some alternative therapy benefits. And sometimes if required, I have read somewhere that the local vaginal applications can work there.
Vaginal applications for? That is genitourinary.
If she is having vasomotor symptoms or
no, local is not going to have any effect because that's never absorbed.
Genitourinary syndrome, if she is having, then local will help.
Then only.
Local you can give.
The genitourinary syndrome. For the menopausal symptoms, we'll have to use some other alternative therapy.
Yes.
See, as Dr. Rajendra told, you can try remifemin and DT56A molecule for long term, and for the vaginal, means she is young, to maintain her sexual activity and all those. So we can give creams. Other creams also there.
Famifene is another drug which has come, which can be given.
Nitric oxide creams and all other creams.
Yes, ospemifene is also one option.
Ospemifene is another drug which can be given for the sexuality disorder in urogenital syndrome.
Because the patient is young. This patient is young. Another question: some people have very bad headaches with any kind of hormone therapy. Maybe a few patients of migraine. What to do in such people? Bad headaches with any kind of hormone therapy.
If it's migraine, then you have to reduce the dose, change the route of the drug, and change the drug also. So if it's given orally, then you have to go transdermal, and you have to change the type of progesterone also. You have to make them micronized progesterone or dihydrogesterone. So that change is going to help them.
So
you can give combined OC pills. You can give
OCPs are going to increase the migraine attacks.
Migraine.
No,
because the dose is quite high.
Low estrogen pills are there now. So you can try.
You have to reduce the dose.
Exactly.
Whatever dose you are taking already.
You have to reduce the dose and add the alternative medicine. Is nutrient therapy safe and better than HRT or MHT? Dr. Mayur Gulargi has asked this. Is nutrient therapy is safe and better than HRT or MHT?
Depends on the symptoms, I think.
Actually, it will be complementary.
Yeah,
yes.
Nutrient therapy
can be tried. 6 months ke liye they can always be tried without any effect.
Nutritional supplements are always better from any medication. Medication is only for those people who really require them.
And where nutrient therapy
symptoms are basically self-limiting. So they will, anyway, if you just learn to live with them, after 1 month, 2 months, 3 months, 6 months, 1 year, 2 years, they will go away. So any therapy, whether isoflavones or phytoestrogens or whatever you want to give, or dietary supplements, they are going to help and they will have a definite placebo effect also. So they can be always.
And the SSRIs and SNRIs are also a very good option for the vasomotor symptoms. If the patients are not able to take the hormone therapies, those are wonderful options.
Because MHT has to be indicated once. You just can't start MHT like that. It has to be really indicated. You have to see the pros and cons, rule out contraindications. Patient should be willing to come for proper follow-up. Then only you can think of giving MHT.
Another question on MHT. Can low-dose OCP be used as MHT? answer is also halfway there and halfway out already given also. Ethinyl and disozestrel in the low dose. So, Dr. Lakshmi.
The low dose OC pills can be given, but as I already said, micronized progesterones are the most effective progesterones. And when you are giving estrogen, if you can give ethinyl estradiol combination, but I mean, you can try, but I will prefer this estrogen and
in the premature menopause patients.
Premature menopause, yes. In the premature menopause patients up to the age of the natural menopause, it is one of the option if the
or even in the perimenopausal period, just before probably it can be given.
In the perimenopausal period when the irregular periods are there, then also and for contraception also at that time, you can use low dose OCP till the age of menopause, and after the age of menopause, you have to change over to the menopause hormone therapy, depending upon whether the menopause was before the age of 50 years or after the age of 50 years. If it was before the age of 50 years, then you continue for 2 years after. And if it was after, then you continue for 1 year, those OCP pills you can continue. And then you come back to the conventional menopause hormone therapy.
Yeah, so switching also can be there. Yeah. Another interesting question about the LNG IUD. Role of LNG IUD as progesterone along with oral estrogen. Role of SERM, it has been asked. So can we give an LNG IUD in place of progesterone?
Yes.
Definitely good option.
It is a good option. It is a good option.
More and more frequently nowadays.
Somebody has said that you said transdermal progesterone doesn't protect from endometrial hyperplasia.
Transdermal estrogen, transdermal
progesterone, she has asked,
does not protect against
the endometrial hyperplasia. Then what is the mode of action of combined patch? Dr. Mangala Vani, she has asked this, that what is the role of combined patch if the transprogesterone doesn't protect the endometrial hyperplasia?
It does prevent endometrial hyperplasia.
What can be done if after 1 year of use of estrogen cream, patient wants to continue with the estrogen cream?
She can.
You should investigate.
She can, but the follow-up is very important.
Follow-up
is very important.
Once you prescribe
after 1 year, if she wants to use, then
prescription on their own, they don't come to you for follow-up. They start feeling good with that estrogen cream. So for many years, they just continue without any follow-up. So here I would like to tell all the participants that
this is our responsibility to inform that
prescription for vaginal estrogen, please write that this prescription is valid for 3 months, 6 months, whatever, valid for 3 months, so that no chemist can refill and patient will come to you for follow-up. Because I have really seen in last 30 years, many patients, they come to you after 3 years, 4 years, doctor, I am taking this cream, I am feeling good. But where is the follow-up? So we should make it
that's a very valid point. So yes.
MHT should write that this prescription is valid for 3 months only.
Or we can explain that
I
in
think
the beginning.
You have highlighted very important point that we have to document it, that it should be given. But if the patient needs beyond that period, then what we should be doing? At that time, then we can do the follow-up with the transvaginal TVS. And if the endometrial hyperplasia is not there, then we can again give it to her. Okay. But your point is very well taken that you have to give in writing. Excellent.
Postmenopausal 5 years with diabetes on insulin without vasomotor symptoms. Can we start MHT? BMI normal? I think if she is without vaso, so why to be given? So it should not be given.
Without indication, should
protection against systemic diseases. That is what I made.
So this message should be very clear in everybody's mind that MHT is only when there are only few indications, valid indications to start MHT. Another question, 45-year working with irregular patient with irregular periods. Pelvic scan normal, FSH is 45. That is perimenopausal level she has given. she has been started MHT, Femostone, but she is now getting withdrawal menses. What to do?
Femostone is not MHT.
Femostone is menopause.
Femostone is
Femostone is combination.
But it is menopause hormone therapy only.
It doesn't have estradiol, madam. I think it is.
It has estradiol plus it has
yes.
It is a combination.
This was the first combination pill which was brought out by the Abbott. And then
people have started.
Yes, the market very early. I told them don't withdraw it because the market will be built up, but you have to give that much time. So it's good because we don't have any HRT with us. Menopause hormone therapy, that is the only combination pill which is there in the sequential manner, continuous combined and the sequential.
So now her question is that it is she is not getting withdrawal menses because it was combined and she must be taking it continuously. So she was not getting withdrawal menses. Now she is thinking what to do. Patient is not getting withdrawal. So now
I think the question was she's getting this breakthrough bleeding or she's not getting withdrawal.
She was not getting withdrawal.
Okay, so
actually,
if the continuation of pill will be there, so she will not get withdrawal.
Yeah, exactly.
No. There is another thing. If she has already gone into post-menopausal age group, then she won't have withdrawal. Yes. It's only in the first 1 or 2 years when she is going to have withdrawal. Otherwise, she won't have later on withdrawal because the endometrium is very thin now.
Correct.
So it's not necessary to have a withdrawal. You just have to counsel the patient.
Now the ball is rolling towards Dr. Vidya. Dr. Vidya, is she here?
Yeah.
One interesting question. Hypothyroidism patients have limitations for eating soy. Please guide.
Soya, she can eat other alternative foods. No, why she wants to? She must be allergic to soya. So she can.
Because of hypothyroidism, she is not taking soya.
Maybe she might not be taking soya, but if she wants to have proteins or other things, she can choose from other food items. No, she need not eat soya only. There are other alternative foods available from which she can choose. Like she can use nuts and she can use almonds. She can use flax seeds. She can use from that. Why she is so much particular about soya only?
Because soya is highlighted much. Because it is highlighted much.
That is a common word. Soya is a common word. So you go on taking your soya board, Nutri-Nuggets, everything. They don't have even proteins to that extent.
Dr. Jyoti.
Is there any cold flashes? Is there any entity like cold flashes than hot flashes?
Dr. Jyoti,
sir.
I wish to add to previous soya because as Maninder told, soya is a common entity, but it's not common entity. No doubt.
Yes.
Even endocrinologists, they are having controversy that soya and effect in hypothyroidism. But as Dr. Rajendra told, other preparations we should try. And in DT56A, in POMSIS trial, they had shown the Femarile and other preparations of DT56A. It is derived from soya only, but that doesn't have any effect on hypothyroidism and other. So you can take safely. So you can
Femoral is option.
Femoral is option, or other flax seeds and all those, they are also options. But studies are there.
The amount which we are taking of isoflavones or phytoestrogens is not going to harm us in any way. We can always take them.
Exactly.
Cold flashes in hot flashes.
I don't
After hot flashes, you always have sweating and cold flashes.
So actually there are not cold flashes, but because of the sweating, the patient later on feels the cold feeling.
Yeah, the word is night sweats.
It is a part and parcel of night sweats. It is a part and parcel of this. Role of vitamin D and calcium very well covered. Status of calcitriol along with calcium also covered. We give hormone for symptoms for menopause diabetic patients. What precaution we have to take? which is the best hormone tablet for the diabetic patient, dosage and how long?
Unless and until it is indicated why you want to start the MHT.
If it is indicated, then if it is indicated, what precautions she should be taking as patient is diabetic?
That applies for all the MHTs.
All the patients.
Specifically for diabetics, I have given you contraindications, high risk factor, and how to do follow-up with these patients.
Yeah,
and of course, yes,
you have very clearly mentioned all the
well-controlled diabetes. Then only we can start. Without controlling, we cannot start.
It has to be
well controlled.
We should be a very motivated patient.
Then we personally, I feel because the triglycerides will be raised in them, so that's why we should give the transdermal preparations in them. That will be much better.
Yes, I have shown this and lifestyle modification. That is what I am saying. She should be a motivated patient with proper consent, counseling, and lifestyle modification. If she agrees to, then she can go for MHT.
Remind all of you again about 21st June lifestyle modification. All of you have to put up your videos. Those who are listening also.
We had talked about tibolone and the lower dose of tibolone as well, 1.25, but the tablet is not available. That is the concern. But one patient can take the half tablet if it is effective for any person. The patient can take half tablet. So as of now, the tibolone 1.25 is not available. The role of teriparatide in osteoporosis. See,
teriparatide is very important when parathyroid hormone concerns. So if there are PTH intact, the investigations we are doing for that. So if it is altered, so we will give parathyroid. There are injections, daily injections available like insulin injections, so we can give that. So parathyroid hormone is very important.
Teriparatide is
for calcium and all that. Very effective.
Teriparatide is anabolic, so therefore
anabolic, exactly.
Yes, so we need to keep
a
watch for.
First line. Exactly. It is not a first line drug for each and every case. Yes, it is very effective, but it is
where anti-resorptives are not working, yes. Where they are contraindicated there, particularly, I think teriparatide has a good role.
And because of time limitation also.
Yes, even here
it cannot be given for the longer time.
Even here there is a time limitation. I think we've had a marathon session.
Yes, really.
Yes.
We are getting feelers from the organizers that we need to stop. So
yes.
Maximum one or two questions. If you feel they are of worth, you can go ahead. Otherwise, we can call it a day. Yeah, you are
one last question.
I think teriparatide can be given maximum for 18 months.
18 months to 2 years, up to the max 2 years.
And it reduces fracture risk. That is very important. Fracture risk.
Yes, sir, correct.
It has a very good effect on spine as well as the other sides. One last question. Here is a patient who is very obese, 75 years of age, having postmenopausal bleeding. USG shows endometrium thickness 7.5. How to manage?
Hysteroscopy.
75 years postmenopause.
Hysteroscopy, directed biopsy.
So I think whether it is 75 or 65 or 55, the line of management will remain the same. And I think it is the time for the summing up of this wonderful webinar.
Thank you very much. Congratulations.
The questions are unending and it is on and on and on. And I must say that take-home messages are always preventions are better than the cure. Manadar Madam rightly said that we should give 1 hour to ourselves every day. This is high time when we should give. Actually, we should be giving it. Actually, we should be giving since our childhood. But der aaye, durust aaye, jab bhi start kiya, at least give 1 hour to yourself for diet, yoga and exercise.
Two things. Stop smoking, all my colleagues who are doing it. And secondly, start exercising. It's never too late. It's never too late.
Thank you.
You can always start any age.
Thank you, Vidya Madam, to giving your so wonderful expert advices about the diet. So I must say that we all should be taking care of our diet since our beginning. Not that बच्चों को पहले खिला लें, husband को पहले खिला लें. Each and everybody, if we will be all right, if the lady will be all right, if the girl will be all right, the whole family will be happy and healthy.
Absolutely right.
So
Absolutely right.
it is. And from Lakshmi Madam, thank you very much for nice talk. From your side, I must want to say, should be saying here that any patient who requires MHT, don't take it on your head that if having menopausal symptoms, this is menopause, we have to bear with them. Don't bear them. Go to your doctor, go to Dr. Lakshmi. And whosoever you are having, and I had to ask few questions, but time limit was there, that how we should be advising our patients, menopausal patients, for their problems during this COVID time. So
we are having another webinar on that. On Monday we are having.
So alternate therapy, and take care from Maninder Madam, take care of and Pardesi sir, take care of your bones. So they will support you, support your bones, and they will support us. Thank you very much, Rajendra Nagarkatti sir, that you have given me the opportunity to join this webinar and interact with you all stalwarts. And I think this is a wonderful time.
Moderated beautifully.
Congratulations to the moderators, Dr. Rajendra Nagarkatti and Jyoti, for doing an excellent job.
Thank you,
so,
madam. Your
motivation.
Thank you so much. Thank you.
Thank you, everyone. Thank you, everyone.
So much for motivating.
Take care of yourself also, along with your patients.
Yeah.